everyone, and welcome to this session. My name is Mark Davis. I'm the Chief Medical Officer for EMEA for IBM. And it's a great pleasure to talk about this really interesting subject of user-centered design and its relationship with innovation. Our title that we're going to talk about is intentionally provocative, that actually health innovation without design is pointless. And to unpack this and explain what we mean by that, it's a great pleasure to be joined by a colleague of mine, Harriet Ruff, who leads our service design unit in healthcare in the UK. Hattie.
Hi, Mark. Thank you so much for having me. So I've got 7 years experience as a service designer working for IBM. As Mark said, I now work in healthcare, but most of my experience is in government, so with clients like Department of Work and Pensions, Student Loans Company, etc. And I'm very much looking forward to digging into this topic with you today.
So it's great this because Hattie, I essentially come from a healthcare background. I'm by professional background, I'm a clinician, and you come from a different world, the world of kind of industry and design. So I'm really looking forward about how we can bring these things together. And one of the things I really want to try and unpack with you is why innovation kind of doesn't deliver in healthcare as well as it does, it does in reality. So in many ways, there is a lot of expectation put on innovation. Most kind of our leaders in healthcare believe that innovation is a critical part to how we reinvent and transform the industry. But most innovations actually don't deliver, and we don't see the benefits that we are hoping for. So what I'm really hoping to do is to talk to you about some of my woes around why that doesn't happen, and see if you can kind of explain to me the way out. How does that sound?
Sounds brilliant. I'll see what I can do.
Okay, let's kick off. So look, the first one I want to talk about is perhaps really obvious, and it's that, you know, in healthcare we're quite a conservative industry, and when people are asked to innovate, they usually start with how we currently do things. So there are quite fixed views around how solutions should be put together. And one of the problems that I see in innovation is actually starting where we are currently rather than starting afresh. I wonder, I'd be interested in your perspective of that.
Yeah, that's really interesting, Mark. And I mean, we see it all the time. And I think the kind of crucial thing that we have to really step back and think about is, what is the problem that we're trying to solve? And the problem that we're trying to solve probably isn't that we need a new insert system. It's probably that we're trying to solve a problem for a human being. And that human being might be a clinician, it might be administrative staff, it might be a patient or a family member, for example. And if we can try and frame the problem in the context of those people, we're already kind of winning. And the analogy that we often use is, if we were kind of given a design challenge and somebody said, design a new alarm clock because we need a new alarm clock. We all have a very preconceived notion of what an alarm clock is, and we kind of understand the boundaries of what an alarm clock can do. But if we reframe that challenge and we say, design a better way for people to get up in the morning, we start thinking in much more innovative ways, and we become much more creative, because what we can start to do is build empathy with the people that are actually going to use that alarm clock. So we can start reflecting on our own experiences. So we can start thinking, okay, I find it really challenging to wake up in the morning. So actually, I just need something really loud and really aggressive. However, some people might want a much more gentle wake up. They might want to wake up with natural light. Some people might need an immediate injection of caffeine in the morning. And we start to think about lots of different ways that people can get up in the morning. And I think the other really crucial thing, and hopefully we'll talk a little bit more about this, is that you start to think about the whole experience, everything that goes around that alarm clock as well. So we don't just start thinking about that one piece of technology, that one digital capability that we're trying to design. We think about where it fits in the wider context of that care pathway or healthcare system.
And Hattie, I've seen you use that example in design sessions with healthcare professionals, and you often start with, you know, think about your perfect hotel and what the values would be of that hotel, and then use that to think about the experience of of waking up. Why do you do that? Because it's quite a powerful exercise.
Yeah, and so value is a really interesting word. And when we think about delivering value, when we're trying to kind of deliver a piece of innovation or a new digital capability, we often think about the money that we might save and the return on the investment. And that obviously is hugely valuable, and we absolutely need to make sure we're doing that. But also there's the impact that it has on the people. And I think you need to have those two lenses when you're coming at designing a new problem. But then there's also kind of key organizational value drivers as well. So as you know, the NHS as an organization has some core values that we always need to make sure we're delivering towards. And you know, a health company that we might be working with might be very concerned about us future proofing and making sure that we're building stuff that's fit for the future. And so we use those kind of value lenses while we're designing, because we might be able to design the most brilliant experience ever for the user, but it might be completely unsustainable in the amount of resources that it's going to cost to implement and run, for example. So you have these kind of designs that come with the constraints that are going to deliver the value that we're looking for ultimately.
I love the way you're talking, because what you're actually saying is you've got a great deal of confidence in the innate creativity of people, and actually what you do is have structured ways of unlocking that creativity and tapping into the wisdom of the crowd, to coin a phrase. And I find that really exciting. And it, you know, someone who's worked in healthcare technology for the best part of 20 years, it's something I really recognize, that distinction between digitizing healthcare, i.e. finding a digital way of doing what you're doing today, and the digitalization of healthcare actually embedding in a kind of rethinking of a delivery model based and enabled by technology. So I love that. That's really helpful. Are you ready for me to give you another challenge though? Because I've got another one for you.
Fire away. Let's see what I can do with this one.
You do well with the first one. So the second one is a bit more contentious, to be honest, which is that we all talk about user-centered design. We all talk about the voice of the user, but of course that isn't the only voice in the room. And there are often, you know, organizational voices and policy voices and, you know, financial return voices and all sorts of interesting other voices. And what I often see in innovation is those voices take precedence as you go through the process, and actually the user voice gets crowded out, and I've seen that happen many times in lots of innovations. And I'm really interested in perhaps some of your experiences from other industries about how on earth you stop that happening.
Yeah, absolutely. So I think the first thing to think about, and I'm obviously biased as a designer, but it's normally the easiest story to tell is the emotive human story. And so it's the easiest kind of buy-in communication strategy for senior stakeholders if you're telling a really human, emotional story, rather than some kind of, you know, financial driven, policy driven type of thing, because you're making it really, really real. It's the lived experience of a patient, of a clinician. And that's the value that we're aiming to deliver. So I think this notion of sort of letting the end user settle the debates is really important. But the kind of the voice that's telling that story might be quite small in an organization if there isn't a kind of practice of design that's quite normal. And so I do think there's this need to kind of embed what we call a designer's mindset across an organization. And so what that means is we don't need to suddenly all become designers. We don't all need to retrain as designers, though it might be lovely if we did. What we mean by that is we all want to make sure that everybody is thinking like a designer. And to be honest, what that means is making sure that they are thinking in terms of the human being that's going to be on the receiving end of whatever it is that we're designing. And that might not be a piece of technology, it might be a process, it might be an organizational change. And it's all about sort of putting ourselves into the shoes of those people that are going to be on the receiving end. And I think if you can move the organization culturally to think in that way, and it's a very subtle change. I don't think it's a huge step away from what most people already sort of think and feel like. That's a really big part of the battle. So I think that's really important. And then also this notion of being able to kind of quantify the user challenges today and allow that story to be the story that sort of, as I say, settles the debates. And then I think the final point is, and I sort of made this point to start with, if you're trying to do a good thing for another human being or an end user, as we would kind of call them, you're fighting the good fight. You're trying to do a good thing, and so it does become the easiest way, I think, to kind of build stakeholder engagement and buy-in for something that you're trying to do.
Yeah, and I love when you talk about users. So in healthcare, when we talk about users, we mean patients generally. And actually the part of the equation that is often ignored are the professional caregivers, the clinicians and others. And when you're talking about users, you're actually talking about all users, aren't you? And I've seen you talk to groups of users around pain points and about mapping pain points, which I've seen being particularly effective. Do you just want to talk me through the thinking around identifying those pain points?
Yeah, absolutely. So, we always try and start with what is the problem that is currently causing challenges today. And ideally, what is the problem for the human beings? And so, we use a range of user research techniques to really get under the skin of what it's like to be that person. So, if the end user was a clinician and they were a surgeon, actually seeing them in their place of work day to day to really understand the challenges. I'll tell a strange story of some user research that I had to do once, which was when I was doing some work on the meat industry, and I had to go to an abattoir because we were thinking about how could we ideally reduce the amount of work that's involved in kind of inputting data, etc. And everybody had these wild ideas of having iPads in the abattoirs and allowing people to kind of input data once rather than having to write it down on a piece of paper, take it back to a computer. But what we realized when we went there is that in an abattoir, it's not a particularly kind of clean and easy place to use an iPad. There's, sorry for being a bit graphic, there's kind of blood and guts everywhere. And everybody has gloves on their hands, the floor's slippery. There is absolutely no way you could take an iPad in there. And so just by understanding what it's actually like to be that human being that's going to be on the receiving end is really important. And so by doing observation, by interviewing people, by bringing people together in workshop environments, we can really understand what it's like for those people. And then we can ultimately document all of those pain points, and often we'll come up with themes, and we'll generally realize that there is some kind of capability that we could build or design that's going to solve a large portion of those pain points. And what it allows us to do is prioritize our work to make sure that we're kind of doing the highest value stuff first. And then I think the really crucial thing is we have metrics to measure those pain points as we're implementing. So we want to generate this kind of feedback loop of traceability back to that user pain point. So again, to kind of make sure that we're always using the user's voice. As we're measuring value, we're not just measuring how much money we might have saved that year, we're actually measuring whether or not we've solved a problem for somebody. Have we been able to move a member of staff onto a kind of higher value task where they can spend much more time with patients, for example, rather than with a computer?
And that's really interesting, because measuring value in healthcare is often quite rightly referred to as evidence. So we do systematic academic evaluation of impact on patient experience or professional customer experience, which is of course enormously important. But as a consequence of our focus on evidence, we've sort of forgotten the other half of that, which is what you're talking about, which is the stories. And actually the way you can drive change, you can drive adoption around an innovation is often just as much about the human story as it is about the scientific evidence.
Absolutely.
Seeing as you've got a story, I'm going to tell you a story, if that's all right. So this is from a long time ago, before I really had ever heard of design. I think I was involved in some work around redesigning end-of-life pathways, particularly for people dying at home. And we had a lot of problem with anticipatory drugs, some of which were controlled drugs, and a lot of problems around the policy associated with drugs being left in the home for someone who might need painkillers perhaps in the middle of the night if they stopped tolerating their oral painkillers. And we were not making much progress. And the other voices around the policy and some ambiguity about the law and prescribing practice were crowding out the simple step of leaving people drugs in the home in case they needed them, who are dying at home. And what happened was we arranged a session, which you would call the design session, to think about how we might think about the pathway. And we invited carers of people who are on an end-of-life pathway, some people who are actually on an end-of-life pathway, and people that have been recently bereaved, to tell their stories. And I can't tell you the emotional impact on the people in the room hearing those stories about when you didn't have analgesia available and people ended up dying in ambulances or dying, an hour after arriving in an accident and emergency department. It completely changed the narrative, and it meant that the user being the strongest and the final vote in the room created the change we wanted to see. So thank you for saying that. It's something I really recognize. I'm going to give you one last challenge, okay, if that's all right, Hattie. And it's my pet subject, and it's that often the experience of innovation in healthcare is it kind of starts off as a bit of a pilot, as a bit of a project. It probably demonstrates some benefits, but when we want to either scale it and make it bigger or more likely replicate it in other organizations, we fall foul, and it never breaks out of what you might call the MVP cliff, that you've done something, it works, but then you can't take it to a more mature, if you like, enterprise-wide scale. I would love to hear your experiences about how you crack that one, because that's really a problem in healthcare.
Okay, so I think there's a few different angles. I think to start with, at the beginning of this sort of design process, it's really, really important to think about scaling to start with. So making sure that when we're designing whatever it is that we're designing, it might be a new service, it might be a sort of a digital product, thinking about, if this were to scale, what parts of the organization might it touch? Who might it be involved in that? And actually making sure that we're bringing those stakeholders from across the organization into the design process to start with, so they feel like the design is being done with them in a kind of collaborative way, rather than something that they might receive a little way down the line that feels like it's sort of been done to them. And so that's about kind of building ownership and making people feel like they've sort of been part of that. And that's really, really powerful and really important, I think. And then there's another piece that I've sort of slightly touched on with the alarm clock, and that's this, and this is what I do, so I'm slightly biased about this, but this notion of service design. So we have user experience design, we have user interface design, but service design is sort of taking a big step backwards away from that piece of technology that we might be designing, and thinking about the context that it sits within, and thinking about the kind of end-to-end service that it lives within. And so if we were working with a bank, we might be designing a mobile banking app, but we will also be thinking about the tellers in the bank, in the branches. We'll also be thinking about the people in the contact center. We might be writing the scripts for them to make sure that the tone is the same across all different parts of the service. And I think by thinking about whatever it is that we are sort of piloting or in MVP stage, if we're thinking about the full service that sits around it, by definition, we're already enabling it to kind of scale, because we've already kind of got our feelers into the other parts of the organization. So I think that is really, really important. And then there's also some kind of, and this is not my kind of field of expertise, but there's also some really important things from a technical perspective as well when we're designing products. So kind of building stuff in production ready code, for example, when you're building an MVP, is so important, because if you're kind of just building a sort of a small clickable prototype, we then have to rebuild it if we want to kind of bring it into a scaled environment. And so thinking about all of this sort of different APIs and different systems and things we might need to plug into as we start to scale, if we're thinking about that to start with, and this is also, this comes back to kind of agile ways of working, making sure that we are kind of moving stuff to the left. We're bringing those technical people into the conversations at the very beginning in that kind of much more multidisciplinary type design team, is really, really important. And then I think the final thing that I'll talk about is adoption. And so you might be building the whizziest, most future-proofed, lovely app for somebody. But if you are not thinking about the adoption of that before you've started building it and how you're actually going to train people to use it, then you've kind of lost the battle, because you're then again you're doing stuff to people rather than doing it with them. And I mean, the best piece of technology shouldn't really take a huge amount of training to kind of embed. You know, this notion of they should just work maybe isn't, that's probably a bit too wishful thinking, but I think again that's this notion of bringing users and bringing the people that are going to be on the receiving end of this technology or service or product into that design process to start with is really, really important, because then you're solving this kind of adoption problem as well.
I don't know what you think, Hattie, but it feels like almost every other aspect of our lives has learned that lesson. It feels like our lives as consumers or shoppers, or, you know, booking a band or whatever, it feels that's intrinsic to how we do business. And in healthcare, there's another thing going on. So look, thank you for those thoughts. I think you and me could probably talk about this all day. I would love to, but sadly we're out of time. I think you've given a really eloquent case for user-centered design with an enterprise lens actually being the forgotten discipline of healthcare. And actually, if we want to make innovation a reality, if we want to realize its benefits, we want to scale it with purpose, then actually we need to get serious about user-centered design in healthcare. So do you think all healthcare organizations need a head of design, Hattie?
Wouldn't that be brilliant? Or we just make all of their C-suite think like designers.
Excellent.
And then
Excellent. So user-centered design is the way we do things around here, huh?
Absolutely.
So Hattie, thank you for the conversation. Really appreciate your time. Thank you to everyone who's listened to this. I hope you find it interesting and stimulating, and we would love to continue the conversation with you. So please be in touch, but enjoy the rest of your day. Thank you.
Thank you so much. Bye-bye.
Well, thank you everyone for joining us. This panel is "The Virtual Health Ecosystem is More Important Than Ever." And I have got some industry leaders here to help us really dig into this topic in a lot more detail. So thank you for joining us for the next 20 to 25-ish minutes. Without any further ado, we'll go ahead and kick things off. I'm going to go ahead and introduce everyone, and then if everybody could just give kind of their quick bio. We have Lori Doherty. She is CEO of Acellus, based out of Florida. We have Cathal Friel. He's executive chairman at Open Orphan, and they're based out of the UK. And then Steve Toll, he is partner at HLM Venture Partners, based out of Boston. However, none of them are actually in those locations at the moment. And I'm Rachel Ford-Hutman. I am founder and CEO of Ford-Hutman Media. We're based out of San Diego. So Lori, could you please kick things off and give everyone a little overview?
Sure, I'm Lori Doherty. I'm CEO of Acellus Health. I've been with the organization for almost 3 years now. My background is in workers' compensation. I've been in the workers' compensation space for close to 30 years now. Did a little stint in Medicare, Medicaid as well, but very passionate about helping injured workers and bringing great programs to the injured workers.
Wonderful. Thank you, Lori. And Cathal, will you please go next?
Hey, Rachel, my name is Cathal Friel. I'm Executive Chairman and CEO of Open Orphan. We're listed in the London Stock Exchange, and we're the world leader in the testing of vaccines and antivirals using human challenge clinical trials. And we're also one of the leaders in collecting real world data using wearables in all of our clinical trials.
Wonderful. Thank you, Cathal. And Steve, last but certainly not least.
Yeah, I'm Steve Toll. I'm a partner at HLM. HLM is probably the nation's oldest healthcare dedicated venture firm. We're based in Boston. I actually live in Chicago for the time being. I'm a 30-year healthcare operator, product manager by training, and have worked in all kinds of segments for payers, providers, academics, pharmaceuticals. So I had a pretty broad experience in the world of health IT.
Wonderful. Thank you, Steve. So, before the pandemic, we were really seeing digital health investments in technology increasing year by year, right? But, 2020 was just a massive year for digital health investment and digital health technologies, right? And you've all seen that play out in different ways. And I would love to, take the next 20, 25 minutes to really dig into that, into each of your experiences. They say healthcare is a 1,000-piece puzzle, and we each hold one of those pieces. And so I'm hoping, through our conversation today, we can put that puzzle together a little bit more. And then specifically talking about telehealth, and how that has skyrocketed. And then what digital health technologies are here to stay. I'd love to get your thoughts on that and what each of you see, the future bringing, and what are the things that just might not last, if we might go back in some ways to how things were pre-COVID. So to kick us off, I really want to talk about the investment landscape. And Steve, I'd like you to maybe kick us off with this one, because I'd like to hear more about what you're seeing right now. And if you think the pace can continue, and especially with these SPACs and all of that.
Yeah, I think the quick answer is no. The pace isn't going to continue. We've seen these cycles before. They come and go. And we're seeing right now very high valuations. We're seeing exit multiples given to companies in their Series A and B, which just is a little scary, actually, from a venture perspective. It can't last. And I think this is a byproduct of some non-traditional healthcare investors, tech investors, who woke up when they saw deals like Livongo with those kind of valuations, those kind of IRRs. Those are in line with what you would typically see in fintech investing. So we've got companies out there raising enormous venture funds, $6 billion venture funds, who have decided to get very aggressive in healthcare. And I hope that they have the same expectations that traditional healthcare investors have about the pace of adoption, about how long it takes a company to find its customer base, to find an exit that makes sense for everyone, because I think that's the concern. We have a lot of high valuation, and I hope that the expectations are realistic about how long it takes healthcare companies to get adoption.
Mm-hmm.
I don't think that's changed fundamentally.
Yeah, agreed. And Cathal, can you kind of weigh in on that and what you've seen, especially, your company's doing so well and the stock is booming, so does that give you more anxiety than less?
No, I think, Rachel, I'm 57 and been around the markets. I bought my first share at 16. So this market comes in 5-year cycles, 7-year cycles. It's almost like a wave. You're a surfer, every 7th wave. The same with the stock market, except the waves are coming faster. Every 2 to 3 years, there's a dip. But if you look at it over a 20-year period, the market keeps going up. As regards healthcare, I think, yes, there's a wash of money, but where's it coming from? Money's free, debt is for free. Central banks are loading all the markets around the world with free money. So naturally we'll end up somewhere where it gives a bit of return. So it's going into healthcare, because I think most things in life are solved, a lot of things. So I think for the next 5, 6, 7 years, healthcare is a great place to be. The pandemic has proven to the world, if you underinvest in infectious diseases, if you underinvest in vaccines, you underinvest in testing, here comes a pandemic. So no, I think it's the most amazing place to be for the next 5 or 10 years. But absolutely, Steve says there is, and look, the public markets research, you've all these unicorns in Silicon Valley, and then the IPO, not so easy. Look, you have the Ubers, the rest of them, the WeWorks, multiple, 33 billions, then they actually listed 10 billion. But that's the public markets, is a great reset. But I genuinely think it's a fantastic time. There's a huge rotation out of, let's say, oil and gas. And a lot of that money is moving into the new oil and gas, which I think is healthcare. The blood in our body is the new oil.
Yeah. I went to an infectious disease conference back in 2018. And I think maybe 2 reporters came to that conference. And it was a big show. But the media just wasn't tracking on infectious disease. It was just seen as kind of boring. And Lori, I'd love for you to weigh in, especially since you had the Series A, last year, and was that easier given the current landscape,
Well, we've seen a lot of interest in our services as mental health and behavioral health is getting a lot more attention. But I would say no. At the time that we were out raising money, it was right at the beginning of the pandemic, and it was very difficult. However, we had a couple of investors that came to the table that had the foresight to understand that behavioral health would be a large component of the pandemic as well as the endemic as we move forward. So we were really pleased and very excited. We had an $8 million Series A that was followed on by HIMCO. We had HLM and 406 invest in us. And so we're particularly pleased and we feel very fortunate that that did happen. I will tell you that the number of outreaches that we're receiving now from private equity as well as venture is unbelievable. Every week in my email box or on my phone, I have somebody else reaching out to want to have a conversation. So, our space is very prevalent right now. It's very hot as behavioral health care is getting a lot more attention.
Yeah. And you guys went virtual really quickly, right? Remind me the percentage of how quickly you transferred the business.
Yeah, it's pretty phenomenal. The team did an amazing job in really a period of about 72 hours. We went from close to 95% face-to-face visits to at least 90, and we're running at 98% virtual visits now. So everything we do today primarily is telehealth. And with that, we saw an adoption of the no-show rate increase, or actually decrease, excuse me. So we went from a no-show rate of around 35% down to a no-show rate of about 10%. So, telehealth, I think it's here to stay for at least a period of time.
Yeah, well, I know for myself, it's much easier when I'm just, getting on a quick telehealth visit versus actually driving, to the physician's office. But I know that a lot of this is going to have to do with reimbursement. And so what are some of those challenges, ahead, for these things, to be adopted? Anyone?
So from my perspective, I think it's parity. And so, as the federal government and various state entities weave through the parity rules. So today, telehealth is easily adopted throughout the country and in the various states. And how will those laws stay, or how will they be regulated or legislated as we move forward is yet to be seen. But I think the movement's here, and I think that there's a lot of headwind in our favor. So I think we're going to see some permanent changes.
Yeah, I think we've talked to a couple of payers here in the U.S. about where they think the market's going to land, and at the end of the day, they're going to get what they incentivize. And so if you look at the types of patient populations or member populations you're trying to serve, some health plans are thinking about a virtual first model where it's a lower cost health plan targeted at millennials, and it's mainly driven by telehealth. So when you think about from an actuarial perspective and where you want your costs to end up and where you want your outcomes to end up, I think payers are going to drive a lot of this parity long term. And you're going to actually I think you're going to see some plans that are almost exclusively focused on younger, healthier populations that are telehealth centric. And then you'll have traditional health insurance plans that have a blend where it's probably end up, 70-30 over time. What I'm guessing will happen. But parity for sure long term is going to be the question, and whether or not payers are going to embrace that.
Yeah. And that's similar with real world data as well, right? We need to see how it's going to be reimbursed and long term, when it's going to be taken more seriously. And that's something I would love to talk more about, especially to you, Cathal, working in clinical trials and all these new digital tools that are being used to collect data. And then this, excitement, for no better word, around real world data and evidence, so if you could maybe kind of talk about that and how you've seen the industry start to move in that direction.
Yeah, look, Rachel, I think we all know the pharmaceutical companies are pretty slow to innovate, but also the CROs are equally slow because it's all around regulatory pathways, and it takes decades to change. However, we're now doing clinical trials and we're putting wearables on all of them. but the wearables is to give us data from day one. The CROs are slowly looking at the future is going to be digital endpoints, but more importantly, the wearables, we hand them to our volunteers a month before they come in. So we're getting almost pre coming into the clinical trial. So that's really important. And then the last thing, we've infected with the British government, volunteers deliberately with COVID. And that's been amazing to watch exactly the point of infection. So again, that could never have been done without wearables. So yeah, I think the future is definitely within healthcare. It's becoming more and more digitalized. And I think it's just like you said, the difference in North America and Europe is quite interesting. Europe has free healthcare everywhere, but it's becoming copying North America somewhat. This 2-tier, you pay to jump the queue, basically. That's how the European system. And now as well, you pay to get access to wearables. So that's where the European model's going.
Mm-hmm. Yeah, definitely. But there's still a lot of challenges ahead, though, for real world data and evidence collection, right? I mean, it seems to me that, you know, a lot of the regulatory bodies are still kind of like not exactly sure about it and how they want, you know, so can you talk more about that and kind of what are some of the challenges that you guys see? Or is that not for you to decide? Is that more for the pharma companies to fight that battle?
Well, actually, I think the battle is for both the pharma companies and the CROs. At the moment, like pharma and the regulators are there to keep everybody honest and protect the world. But regulators are government officials, and it takes decades to change a single protocol within the FDA or the EMA. So bear in mind, it's taking time. But I think they're getting there. And the CROs are changing in the way they harvest and collect data. And the pharma companies in particular, we've got the world's largest database of infectious disease collected for testing challenge studies. We've now lots of pharma companies come and say, please, can we get access to your infectious disease data so we can power some of our studies? So the market is actually probably moving ahead of where the regulators are. I think the regulators will catch up. For instance, now they're saying post-authorization in Europe, the EMA are saying you actually have to collect quite a lot of data using the wearables. It's not a critical part of the pathway, but it's recommended on the post-authorization requirements.
Mm-hmm.
I think there's going to be an interesting overlap between real-world data and digital health. So we start to see some of these health systems, you know, the new joint venture that was just formed by the 15 or 16 health systems to start mining real-world data. Clearly, there is a perceived business value in pooling data and making it available to people that need it to build offerings, build products. I think where you're going to find an interesting overlap is when the consumer actually uses a digital health service to do patient-reported outcomes, for example. But once the consumer gives rights to their data, that trumps all the other privacy concerns and privacy thresholds or hurdles that real-world data has faced. So I think we're going to start to see an interesting overlap between consumers using digital health tools and powering more of the real-world data effort.
Yeah. Yeah, isn't it so interesting how people in your regular lives now have more understanding about what it is that we do? I'm just so fascinated, you know. I mean, just my aunt or something will be like, "Did you hear about Livongo?" Like, what? You know, like these are just things, or clinical trials. You know, it's just so fascinating how now this is really part of you know, the global conversation is so focused right now on digital health, on healthcare. You know, I've heard people say too, kind of now is our moment to move these things forward. And we can't drop the ball because right now the world is kind of watching healthcare in this whole new way. And if we don't enact some of these things quickly, then it might disappear and we might go back to pre-COVID. I hope that's not the case.
You gotta think that after spending trillions of dollars and billions of euro, that the taxpayers are going to expect and the governments are going to expect progress. And I think we've all been, you know, amateur virologists for the last year trying to figure out what's going on. And I think we've also all been kind of surprised that with all of the electronic medical records that the world uses, that we still don't know why some people get sick and some others don't. And I actually think it's driving a lot of interest in where this market goes next, because we should have better fidelity to this kind of data. And of course, the average person has no concept of how hard it is to do this kind of research and the kind of controls that have to be in place, right? But because we've spent so much money, and this will come back to us as taxpayers in every country in the world, I do think there's an expectation that the market will make progress, and that's part of our job, is to spend that money wisely.
Mm-hmm. So what is next? I'd love to hear from each of you kind of what you see is around the corner. And this doesn't necessarily have to be necessarily about your business, but kind of technology at large. I think, what are the things that are getting you excited about digital health right now, and where you see the future going? Lori, you want to kick us off?
Sure. I think, from our perspective, we're able to reach a lot of those injured workers that we potentially couldn't have reached before because of concerns around transportation. We are dealing with injured workers in every segment of society. And so some folks just couldn't make it to treatment. So telehealth gives us, or televideo gives us that capability to reach injured workers. And we're seeing encouraging outcomes. So 92% of the employees that we work with return to work within the projected timeline because they do attend their sessions. They are able to make those sessions and get the treatment they need. And then what we're seeing is 93% of the patients achieve meaningful reductions in stress and anxiety. And I think one of the things that we will continue to see, at least over the next 18 to 24 months, and we don't have that crystal ball, is an increase in stress and anxiety. And I think we haven't even touched the tip of the iceberg relative to the opportunity there.
No, we haven't. A lot of the things I've been reading have said basically we're going to see the real mental health effect after this wraps, which terrifies me.
It is terrifying.
Yeah, that we haven't even been able to start to understand the mental health effects yet because we're still in it, right?
Correct.
Yeah.
I think there are 4 things that drive adoption in healthcare, right? One of them is regulation. Nothing better than a good regulation to get something adopted. Then you've got risk. How do I manage my risk? Then you've got revenue. Can I enhance my revenue? And then finally, is there a return? Is there a savings? Those are the 4 R's that drive adoption in healthcare. And if you think about what's happened in the pandemic, and you've had these huge employers have to push all their employees into the home, that's broken every traditional model of how you engage employees, measure their progress, evaluate them, give them promotions and salary, right? It has upended the entire workforce. So things like resilience in an employee population, that's got to be a huge stress driver. So we're going to see that on the back end when people have injuries or have other health issues. I think we're going to see a lot of interest in substance abuse treatment. The numbers are shocking. 5% of 8th graders in the United States say that they've used meth. It just blows your mind. And you're going to see on the regulatory front, the data transparency laws are going to drive a lot of behavior from health systems. Some of the balanced billing policies are clearly going to drive behavior and adoption of technology. So we see some regulatory good guys out there that I think will help push solutions that we've needed in the market for a long time. So that's how I look at, where's the angle for adoption when we try to make an investment? What's going to drive the adoption? And we're always looking for kind of a blend of those 4 levers, but you need at least one of them to really push a company along.
Yeah.
I think, Rachel, the big adopter, and I think human nature is really interesting. We have changed. Doesn't matter. We're not going back. I think the pandemic, I believe, is going to have huge positives. Yes, mental health is going to be issues, but if you think about it, here we're doing this Zoom. I'm in London, Europe. We're spread around the world, and we can do it easily. So that telehealth, you're absolutely right. Steve said most 18 to 30-year-olds have disappeared. They're not going near a doctor, but they can do the telehealth. So I think as we go forward, there's going to be, I would say, short-term mental health issues, but I think the whole world is now, we're all part-time virologists, we're part-time epidemiologists. So we're using the internet. The internet has helped it. Imagine what would happen if we didn't have 4G and we didn't have proper Zoom. We'd never have got through. It was just humans were lucky. And I think going forward, I keep saying there was industrial revolution. There was almost the hydrocarbon revolution. But I genuinely think we're going to a decade or 2 now where people are focused on their health. I think look what President Biden's trying to do for the first time since Roosevelt. He's trying to reset the American economy. The Europeans have had a reset. So I think I'm never been more excited. I think we'll never go back. before Zoom, like we're on this in Zoom. And as Steve and Laurie said, there's a whole new way of working. But like the big one, the big revolution, I think, is the 9 to 5 commute to work is over. People have a choice. Yeah. And there's going to be very few, I call worker bees, drones, work environment. It's almost like the science fiction movie has arrived. People have choices.
Yeah.
Yeah.
Yeah. So one final question. We're out of time. I'm just curious what you each think about going back to conferences and events. Are you looking forward to that? Steve's laughing already. Are you looking forward to being in a big conference with a ton of people, or are you like completely terrified? Steve, you got to go first.
I can't wait to get out of my house. I will say I went to a board meeting last week. I'm vaccinated. I went to a board meeting last week, and I expected everyone to have their mask on, and they were all shaking hands. And I had such a visceral reaction. Like someone took their hand out. I'm like, what do I do? So, I think we're going to have some behavior change, but I can't wait to get back out. And I think later this year, we'll see some of that return.
Yeah. Can we do away with the handshake though? I've always been a little germaphobe about the handshake. And so I'm personally hoping that this does just do away with the handshake.
Yes.
Cathal, are you looking forward to getting out of your home, sir?
Well, unfortunately, I'm terrible. I've worked from home 3 days in 12 months because we're testing vaccines. So my wife says I don't realize there's a pandemic. But no, look, where I think the big events, multiple events, we'll all look forward to JPM, JP Morgan. It will happen, things like that. It's an excuse for us to wait. But I think an awful lot of the mini events are over. Yeah. You can do them via Zoom. So there's going to be big trademark, landmark ones where people, it's to get away, it's to meet people. We can make some more, but I think so many events, unfortunately, will be done by Zoom. They'll become much more practical, business-like. Look at British Airways and Europeans. They've said air travel, business class is never going to return. HSBC Bank in London announced it's banning most business travel by at least 50% pre-pandemic, and they announced that the world's largest bank, HSBC, said business class travel is going to have to be reduced formally by a minimum of 50% post-pandemic. So yeah, looking forward to it. But as I keep saying, the change has arrived. We've evolved. Yeah. We're an evolving species. It's a bit like the movies, and we're going to evolve further and faster in the next 10 years than I think in the previous 75 years as a human race. That's my view.
And Laurie, how about you?
I agree with both Stephen and Cathal. I'm anxious to get back out and go to conferences and around people again and have that collegial spirit. Similar to Steve, we had a board meeting last week, not the same board meeting, but I was at a board meeting and the sidebar conversations were just amazing. I missed the collaboration. I missed that, spontaneous capability just to sit down with somebody and, be creative. I don't think you can do that via Zoom, but I agree with Cathal. There's so much we can do via Zoom, and so business travel will never be like it was before. But I think those industry conferences and opportunities are really important for us.
Yeah, I agree. I'm going to be very selective, I think, with what I attend and what I go to. And, that is going to be great for the environment as well. So, well, thank you all for your time. Really appreciate it. I know I've learned a ton, so hopefully our listeners will also. All right.
Rachel,
later.
Steve, Laura, thank you very much.
Hi, everyone. I'm Amanda Heidemann, and I'm a consulting CMIO. I work with hospitals, healthcare organizations, and healthcare IT providers to help them through their digital transformation journey and help develop strategies to build the technology of the future, to get patients what they need, to be better partners in their care, to get families and caregivers involved and empowered in their care. And when I'm not doing those things, I'm seeing patients in the emergency and urgent care settings.
Hi, Amanda, and all of you listening in. My name is Andy Cantor, and as was mentioned, I'm Chief Medical Officer for Intelligent Medical Objects. I'm an internist and a sort of public health doctor, done a lot of work in global health. I wear a couple of different hats, including assistant professor at the Department of Biomedical Informatics at Columbia University and the Department of Epidemiology. And I sit on the board on global health for the National Academies of Science, Engineering, and Medicine. So I'm going to lead off today, and we're going to have a bit of a dialogue back and forth with Amanda about this topic. And so I'll start first by telling you a little bit about IMO and why is IMO even involved. I've been with the company pretty much since its founding in 1994. We represent, or actually sort of coined the term of interface terminology. We provide a infrastructure for health information systems across the country to help providers capture and document clinical care. We're in over 70% of the acute care facilities and have over 500,000 physicians using us daily in the United States and across the many of the English-speaking countries. And I'm going to talk a little bit about clinical interface terminology and why it's so important to the topic that we were going to be speaking about today. So first, it's interesting to kind of take a look back and look at how the challenges in healthcare have evolved over time and sort of what the role health information systems have actually played in solving some of those challenges. And prior to clinical interface terminology, many of the health information systems were not being used by clinicians. And you'll hear a bit more from Amanda in a bit about those early days. But it really required the use of clinically friendly terminology in health information systems that allowed providers to actually use these systems and actually be able to use computers to document important aspects of patient care. But as time went on and as clinicians were starting to capture parts of the encounter and parts of the medical practice, more and more burdens were placed on them to drive different kinds of activities. So the next one that was probably most obvious was the use of standardized codes to drive clinical quality reporting and reimbursement. And so it was really essential early on to be able to not only collect the clinical documentation, but to drive these other processes that were incentivized by the HealhTech Act and meaningful use. And so this is where clinical interface terminology played a really important role, because doctors just want to speak doctor. They just want to be able to document and see within the electronic health record the content that is most relevant to the care of the patient and in the way they want to speak about it. So there are many different ways to say things like heart attack with ST elevation, and that we want to be able to capture all the different ways that a clinician might want to be able to say that concept. But clinicians don't need to be coders. And so interface terminology basically takes that clinical concept and assigns it the kinds of standardized codes that are necessary for computers to actually understand what the doctor is trying to say. So these include things like the billing codes and being able to drop information for reimbursement, but also really importantly, other kinds of reference terminologies that are used for helping drive things like clinical decision support, artificial intelligence, and we'll talk a little bit more about that in a bit. But this is where we are right now. There have been some additional challenges in the way. New coding systems have come up, introducing new payment methodologies and new kinds of quality measures have all been introduced. And just prior to March of 2019, we were expecting this new government regulation to come in, similar to the HealhTech Act. It was called the 21st Century Cures Act. And that was going to introduce a whole bunch of new regulations in improving the interoperability of health information. And I'll talk about that in a minute. But that's what we were really expecting to happen. But what we didn't expect to happen was the COVID-19 pandemic. And that really drew a lot more attention to these particular issues and made this concept of sort of population health and value-based care and looking toward sort of the future of preventing the next pandemic to the forefront and center of our activities. And it will probably be that way for the next year or two. But let me say a little bit about the 21st Century Cures Act, because this was what was happening at the time. essentially, this is pushing forward the general principles of increasing innovation and competition within in the healthcare environment to hopefully improve quality and reduce cost. There was a real focus on reducing clinician burden and advancing the interoperability of data, which is allowing data to move between systems while retaining its meaning and sort of its actionability. And then it was really trying to bring the patient back into the center of healthcare by promoting patient access. And this was where we were at, and we were anticipating that this was going to be the major challenge that we were dealing with. And so if you sort of summarize the 21st Century Cures Act, there's two main areas that was important. One was this notion of increasing the sort of ability of data to move between systems. This was kind of like hardware and software interoperability processes. And you can think of this as sort of like greasing the skids to make it easier for data to flow back and forth. But the 21st Century Cures Act also identified that there were these sociological barriers to information flowing, and that oftentimes providers or health systems weren't incentivized to share the data with patients or with other health systems. And so they actually put in penalties to prevent what was called information blocking. And so when you took these sort of the physical interoperability standards and sort of added those to increasing or decreasing the obstacles associated with information blocking, we were really anticipating that there was going to be this data tidal wave, that there was going to be lots of data flowing around within our health ecosystems, and that was going to put a significant challenge and burden onto both patients and providers. But what we really didn't recognize until it actually happened was COVID-19. And we know that what it really did was significantly up the ante on these exact challenges about data sharing and data access, and that the pandemic itself really demonstrated that although we had sort of on paper thought about many of these topics, that there really were gaps within the health information systems and what we really hope to gain out of them during such a critical time as this. And as you looked at the actual arc of the pandemic, the kinds of information we needed and the way that information was going to be used really changed over time. And initially, it was all about capturing the extent of the disease. What was, do we have enough ventilators and isolation beds available to take care of it? But then in the middle, it was really about understanding what was happening with the disease. And on there were opportunities for learning more about the disease. There were some really awesome spontaneous consortiums that globally that actually arose, which was really heartening. But there was real challenges as well to the health system. And I know, Amanda, you were in the midst of it, in the trenches. What was it like for you?
Yeah, definitely some challenges. And even at the beginning, just the ability to be able to report what we were seeing. So being able to capture COVID-19 as a disease state and not having to just put something like viral syndrome in the chart or document it based on the symptoms or things like fever. To get that data of the granularity that we would need to analyze it and be able to make it useful going forward. I know that was a big day when we actually got the appropriate code entered into the chart, the appropriate ICD code that we could all use to start documenting that and use that for our reporting. But it also, it accelerated interoperability in some ways, and some things that we worked on with electronic case reporting, things that organizations had struggled with in the past about reportable diseases that were just in a pilot state, and boom, they were immediately accelerated into production, and it was truly tremendous. But yeah, it really illustrated how important the data truly is.
Yes, and I think back on the time when I think I was flying back from an international meeting at the end of the year when it was just starting in Wuhan, and realized, hey, this is going to be a problem. And so IMO had actually interface terminology to capture the initial symptoms and diagnosis of COVID back in really in January of 2019. And so there was a real opportunity for us to begin to use clinical interface terminology to capture the level of data. But what we realize is that this kind of topic and the kinds of levels of data necessary for COVID and for what you'll be talking about in your story coming up is still needed, very much needed. So this combination of the increased physical interoperability of data, the decreased the decreased obstacles to blocking or to passing the data back and forth, and then the context of the pandemic dramatically increased the requirements on the healthcare industry to better manage data and be smarter about how we do that. Because if we really don't handle this properly at a time when providers themselves were at the breaking point, even prior to the COVID pandemic, that this tidal wave of data had a real danger of flooding the system. So some of the things that we wanted to talk about at the hospital of the future is really how can we better handle data? How can we make it more effective and in a way make it for us to be able to actually ride this wave, use the power of the wave to actually improve the quality of care and hopefully the standard of living, or not the way that physicians actually and other providers provide care. So I'm going to talk a little bit about, I think, from my perspective, before Amanda starts, about where we sort of ran into trouble and where we need to be thinking in the future. And as I mentioned earlier, these systems were really initially designed as sort of glorified billing machines or practice management machines. And over time, historically, electronic health records have been viewed primarily as these kind of passive data stores. The more information you could stick in there and the clinician could put in there, the better. And that there was going to be someone on the back end who was mostly responsible for deriving the value from that data. And so whether this was risk stratification or reimbursement, it was typically those kinds of things. And that the providers were really stuck because they had all the burden of doing the data collection, but they really didn't have that data available and accessible to actually take care of the patients. They were sort of blindly asked to kind of reach into this big database and pull out the right information at the right time for the right patient, and this was a real challenge and was leading to their burnout. So I'm going to talk about slightly maybe a different paradigm, and it's something that I think we can actually all arise to and be part of this hospital of the future. And that is that health information technology is actually a communication medium. And so we think about today, most of the care is actually provided not just by me alone, or Amanda alone, but by a team of people working together. And so I'm entering data into the health information system as a way to communicate with all those other members of the team so they could truly understand what's going on with the patient and be able to collaborate and do the best care as possible. More and more patients are actually being included in their care and the decision making around their care. And so that, whether it's through patient portals or through things like open notes where patients are actually reading the documentation directly, the electronic health record is the way that I often will communicate directly to them, not only in the office, but how they are able to connect with that health information in between office visits and after they've left the office. And lastly, a really important point is that the EHR is really how I communicate to myself over time. And it's not that I just can't always remember what happened 6 months ago or a year ago when you were in the office, but there was a certain kind of thought process that I had in place. I had certain clinical decision in place. I was differential diagnosing. I might have been looking for particular tests to be done. And so I actually put the information into the EHR so that when I then see you again, I'll see all of that thinking plus all the additional data that my team and other information that has come into the medical record. And so this notion that the data or the EHR or the health information technology itself is not just this passive database, but it's really a way to communicate within this ecosystem and with myself in general is a really new paradigm. And the challenge is that the way data is being collected at the point of care to serve that particular reason in that particular encounter doesn't always fit the way the data is going to be used to communicate to other members of the team or to do population health or to trigger clinical decision support rules. And that data actually needs to be pulled together and aggregated from different sources. It has to be normalized so that the same language across all those different information systems. It really needs to be transformed into the right format to be able to serve a very particular purpose of the patient in the office at that particular time, or the public health purpose, or maybe it's the cancer registry purpose. And lastly, it really needs to be summarized and presented to the clinicians in a way that actually supports their care of the patient and not actually overburdens them. So I think if we look at this arc of time from how important clinical interface terminology was to sort of getting clinicians to actually use the system, to be able to capture the data at the right level of specificity that a clinician wants, and then think about how we need to be able to start having these systems work together, and those systems be more effective at leveraging clinical decision support in the future, is going to be the basis of our kind of conversation going forward. So I'm going to stop there, and I'm going to turn it over to Amanda. So now you can talk a little bit more about your personal experience, and then we'll come back later for some dialogue.
Great. Thank you, Andy. So as we kind of talk a little bit about my personal healthcare data journey, as a clinical informaticist, I've been involved with maintaining patients' protected health information and maintaining their data for a long time. We want to make sure that we have solid data integrity so that we can use that data downstream for a variety of different things. But it doesn't necessarily hit home until we actually go on our own personal healthcare data journey. And I don't think any of us really expect to do this. We never wake up one morning and think, oh, today's the day that I'm going to become a patient. But, I'd like to tell you a little bit about just kind of some of the different ways that this has impacted me along my career. And also, I think it's just so important to understand where we've been with the data. Where are we coming from? As Andy mentioned, with the evolution from billing systems and just trying to get the data into the vault to now we have this data, what do we do with it? How can we use it to really improve care and empower patients? I think we need to understand that past so we can inform to the future. So a little bit more about me. I've wanted to be a doctor since I was 4. One of those kids that, there's pictures of me at my birthday with my Fisher-Price doctor bag. And, but as a kid, you have limited interactions with healthcare for the most part, many of us, if we're fortunate enough to be healthy. So my first real interaction with a healthcare system started when I was in high school. And that was where I got to play the role of being the family member, interacting with healthcare and interacting with healthcare data. So when I was a junior in high school, my mother was diagnosed with breast cancer, which is, still even today, such a big diagnosis and a big change in things for patients and for their families. And especially challenging was that she was very young. So she was 44. And when I think back about, going to visits with her and trying to support her on that journey, I was part of her care team. I didn't really know that at the time. And we didn't necessarily think of families as being part of the care team and needing access to that data. But, I got to have access to the data because I was there. And I also got to witness some of the beginning stages of patient empowerment and physicians who were trying to document to help patients understand and to lay the groundwork for patient engagement with their care. So my mom had one of those doctors that would actually dictate at the desk with the patient at the room, the little micro cassette recorders that we used to have. And thinking back, that was really something. But that data was still locked up in those manila folders. So the only time it ever got utilized was either if it was being sent off for a bill or if someone was at a subsequent visit looking into that manila folder. So at the time too, healthcare was evolving, not just the data and the healthcare information technology, but, things like genetic testing were not common for breast cancer patients then. That was right when BRCA was being discovered and put into regular use as a gene. So, really that manila folder was just, a diagnosis, a summary of notes of how she was doing with her treatments, and then some pathology reports. So fortunately, she did very, very well with her treatment, and that motivated me to continue on, in my pursuit of being a physician. But then, as I moved on in my career, I get to experience different roles. So the next role I played in the interaction with data was as that of a medical student, and then also, got to be fortunately or unfortunately, a family member again. So during my third year of med school, I had a grandmother that was diagnosed with colon cancer. And it was kind of a surreal experience because she was being treated at the institution where I was training. So, there were certain rotations that I avoided and had to shift around for that. But as a student, you start to really understand the role of the medical records in the treatment plan and kind of what this data might mean to me. There in the late 1990s, we were starting to have electronic health records. Mostly they were digitized versions of patient flow sheets and kind of some rudimentary problem lists. I remember thinking it was really cool that you could look up pathology reports on these green screen terminals. Thinking back, it's a little bit of a trip down memory lane, but technology really has come a long way. And Andy, I don't know what it was like for you when you started using electronic health records in your training.
Yeah, actually, I was actually pretty lucky because when IMO's early days actually involved developing electronic health records, and during my training period, I was actually able to help develop one, and so that gave me a little bit maybe more power to utilize the technology. But I clearly saw, even at the very early stages, the benefits of being able to collect data on my patients and actually be able to see it. And when I rounded on the patients, to be able to actually have it automatically summarize it on a piece of paper for me saved so much time in those little cards, that used to keep in our pockets. But I also saw just how it distorted the interaction, right? And it was so much of a challenge through the very kind of clunky user interfaces, and even now the challenge we have of having to use a computer while I'm actually seeing the patient. So, I saw the potential, but also saw a lot of the challenges associated with it.
Yeah, I had kind of forgotten about all those cards, and it brings back some fond or not so fond memories. But
PTSD.
thinking back to from a personal standpoint, at the time there really wasn't a good way to aggregate data for the patient either. So, if you wanted a copy of your medical record, it was up to you to ask for photocopies and to take those home and maintain them. Maybe you had the ability to scan them, or maybe you just stuck them in a manila folder at your own home. But the record was still mostly narrative. And even though we were starting to get some genetic testing and other outstanding technologies for treatment, everything was still pretty siloed and locked up. So things remained the same for a long time until some different programs spurred many of us on to electronic health records. But unfortunately, the next part of my journey became not only as a family member and by then an attending physician, but also as a patient. So fast forward about 20 years, it's a very different world. In 2017, EHRs are abundant. We're all putting in all of our data, thanks to programs like Meaningful Use. We've got that tsunami of data that we're building up. But again, we don't necessarily have the ability to unlock that data, even though it's in the chart. Being able to utilize it and leverage it for clinical decision support and functions like that was still really evolving. But by this point, my mom, fortunately, had been a 27-year survivor of breast cancer, but we got that phone call that you never want to get, which is, I've got breast cancer again. And that was very interesting because now genetic testing is everywhere. EHRs are everywhere. There's all kinds of data sharing among research institutions. And one of the highest recommendations that she got was, to go ahead and have the genetic testing. And unfortunately, due to her results on the genetic testing, that meant that I became a patient due to my genes. And that was a very interesting experience. As far as trying to understand what all of that means, and then putting on my informaticist hat, trying to go back and figure out, okay, where are all these records and where is all this data, and how can I use it to better inform not only her treatment that she's getting now, but also my own treatment plan. What's my plan for the next 40 years as we work through this. And even though there's been some strategies and some fits and starts to make that data more visible to the patients and to the families and the caregivers, a lot of those opportunities like Microsoft Health Vault and some other independent third-party data aggregators, those have kind of gone away. So, now that I was squarely in this patient role, I was really motivated to figure out what I could do about this data. And that's where I got to really play the role of clinical informaticist, trying to sort that data out. So I had been to see a genetic counselor, and kind of those records were tucked away until earlier this year, when all of this came to a head a little bit. And part of it was due to COVID, and I'll tell you about that. But in my house, I had a little folder with everything from the geneticist and my own testing and kind of the beginnings of my own patient journey. But lo and behold, here comes COVID. And as we all know, COVID delayed a lot of services for patients. A lot of mammograms got delayed. A lot of colonoscopies got delayed. And I was certainly in that bucket. So as someone who has a very high risk for breast cancer, I was enrolled in a high risk program, and my breast MRI got bumped due to COVID. So it was supposed to happen in the fall. Here comes COVID. We're having the big fall peak that we had in the fall of 2020. And so it got bumped until January. So, I go for my routine 6-month screening, and now I've got something going on. And I've got this rogue lymph node that's new on the MRI, which is, of course, abnormal because of it. And, at the time, there was some debate back in January about, could this be due to the COVID vaccine? It's on the same side as the COVID vaccine. And I think this is really where we saw the power of that data, and for organizations to very quickly be able to drive clinical care based on the data that it was at their fingertips and based on the data they could easily share. So when you've got organizations that are able to document in the patient chart, not only, hey, there's a lymph node, hey, this is a high risk patient, hey, this is a woman who had a novel mRNA vaccine within the last 6 to 8 weeks, it actually drove a revolution in clinical care around mammography, MRIs, and breast imaging. So radiologists got together, they shared information, they realized that this was probably a phenomenon from the vaccines that was leading to a lot of false positives and a lot of concern and, a lot of, emotional challenges for patients. And within a period of about 6 or 8 weeks, we had new recommendations on the table, new clinical decision support that said, if you receive a COVID vaccine, perhaps you shouldn't get a mammogram or other breast imaging for the next, 6 to 8 to 10 to 12 weeks, depending on your history, so that you have a greater chance of not having one of these anomalous values. So, it really just showed that data was king. And without having that discrete data that we could all analyze, we would have never been able to do that. We would have never been able to see those temporal relationships between the vaccines and healthcare workers, a lot of us, who are women, and these abnormal tests. So while this was unfolding, though, I was on the leading edge of this, and before we had new recommendations. So in the meantime, I get sent to a breast surgeon. When you've got a 40% lifetime risk, that's where they send you next. So I went to the Manila folder and pulled out my genetic consultation from 2017. And I really got to thinking about that. And literally that consultation doesn't live anywhere other than in a hospital chart, because it was a hospital that I had the consultation through, the hospital chart and my Manila folder. So it doesn't live in my outpatient record. It's not something my OBGYN or primary care physician can see. So I pull out the genogram and I start thinking about it, and maybe I should have some different testing based on this new situation. And it really struck me looking at the genogram. And actually what you see on the slide is my genogram. So, all the color represents cancer. So we've got a little bit of it in the family. But then you look at what's in the generations following. And as an informaticist, I really think this is just fascinating, because we have the ability now to do better prediction on what's going to happen to all those people that are the white circles and squares. We can use that data to drive how we care for them, how we do surveillance, whether we start screening them earlier for certain kinds of cancers, et cetera. But it also struck me that not only do we have the opportunity to intervene, but where does that data live and how is that data going to be used? Because I'm the circle kind of towards the bottom left, and there's 2 squares below me, and those squares are my sons. So my sons need to have documentation in their chart that represents my risk, because my risk is actually their risk as well, based on the genes involved. But how does that get documented? And does it get documented at a level of granularity where it can make a difference, where it can play into clinical decision support, et cetera? So I got to play yet another role in this, and got to put on my mom hat. And, this is some of those conversations you never think you're going to have with your kid. Hey, let's sit down and talk about underage drinking and genetic surveillance, because, maybe we should go have some blood drawn. And, I kind of joke about it, because sometimes when you're in these situations, humor is one of your most powerful treatment strategies, because nobody likes to think about cancer. Nobody likes to think about the potential for that. But we do need to think about getting the right information at the right place at the right time, to make it actionable, to make sure that that data is precise and make sure that it's accurate. And really, the root of all of that is having solid clinical terminology. So knowing that those family histories, it's not just thyroid cancer unspecified, which actually was what showed up on my genetic consultation for a family history element. Knowing is that thyroid cancer, a papillary cancer, or a medullary cancer, because one of them is hereditary and one of them is not. So those things are really important. And being able to get that data discrete and mapped to a terminology so it can be shared and so that it means the right thing to the right people looking at it. So making sure it's in a patient-friendly term when I see it through a patient portal, something that I can understand, making sure that it has the right level of specificity when it goes into a clinician chart, when it gets attached to a pathology reading or something like that, where we want to know really, really how specific that data is, being able to flow that through. And I kind of have this vision of the future where you ask somebody, oh, send me that contact card on your phone, and you text it over. I have this vision of showing up at a family reunion and sharing your family history data contact card that you could all exchange data easily, and then your relatives could put that in their personal health record or add that to their electronic health record. And then everybody has that information at their fingertips, rather than have it just be something that's, anecdotally talked about at the family fish fry once a year or something like that. But my story is not unique. We hear about these things all the time. I think sometimes they really resonate with us more just because we're in healthcare and we see the power of the data and what it can do. But there's a well-known blog, Dr. John Halamka, who's a well-known physician informaticist currently working with the Mayo Clinic platform. And actually, several years ago, he blogged about his wife and her breast cancer diagnosis and their journey and basically what he encountered as a clinical informaticist. So, Andy, I think you and I have talked about that story a little bit.
Yes, and Amanda, you really bring the whole story home on a very personal level. And so I think both your story and Dr. Halamka's story it's important to recognize that these are both real people, and it's not just this academic discussion that we're having. But I think what Dr. Halamka realized, also as an informaticist and also someone who's going to be able to go and do research, was that breast cancer is treated differently depending on what type of breast cancer you have and how far along it is and so on. And so he was luckily able to use a clinical interface terminology within his record to identify that his wife had stage 3 breast cancer, and that there were very clear consequences of that in terms of the right types of treatments and the right kinds of care protocols. And that normally to try to get to that characterization of the cancer, like the staging or whether or not the estrogen receptors were positive or not, requires pulling together all these different data elements that are scattered across the health system. And often they're not even in the EHR, they might be in a laboratory system or an anatomical pathology report. And so by having this highly granular term, he was able to sort of utilize that to drive the specific care that his wife needed. And that's just one example of where the right sort of terminology and putting the providers back in sort of control of the underlying health information that made it possible for him to get the best care that he could for his wife.
Yeah, and I think that's at the end of the day, us as clinicians, that's what we want to do, is we want to give our patients the best care possible. And really having that knowledge and not only having all the data available to us, but being able to unlock it and use it in a way that's actionable, being able to drive clinical decision support, being able to do alerts and care plans and things that help remind us of what we need to do. Because let's face it, clinical information and scientific information, it is doubling at an exponential speed. And, we as clinicians, we can't possibly remember it all the time. And I think it's really great that we can harness these information systems and use those to prompt us to make sure that we take the right actions at the right time for the right patient, and also to help empower patients in their care. I really think that some of the new things that are evolving over the last year or so, including open notes, which really became mandatory within just the last few weeks, I think that's huge. Being able to look at your own records and even when you find something that might be concerning, being able to have that dialogue with your physician, with your care team, so that everybody has a greater understanding of the healthcare situation moving forward.
My name is Rachel Ford Hutman. I'm the CEO and founder of Ford Hutman Media. We're a communications firm specializing in healthcare and technology. And we are so happy to have you with us today to discuss such an important topic. COVID has really brought to light many of the gaps in our healthcare system. And today we're going to be discussing what those gaps mean. Especially, we're going to be diving into the deferral of care and treatment. And then we also want to talk about what that means for the future and really how we can do better. And we're going to be discussing this topic with an industry leader. And I'm so excited to introduce him, Dr. Oswin Chandra-Kantan. He's the Chief Medical Officer at Komodo Health. Komodo Health, if you're not familiar, it's a real-world data and analytics company that combines data on patient encounters with enterprise cloud software to connect the dots between individual patient journeys and large-scale health outcomes. And with that, I'll let Dr. Chandra-Kantan introduce himself and please share a little bit about your background as well.
Sure. Thank you all for having me today. My name is Oswin. I'm the Chief Medical Officer of Komodo Health, doctor by background, management consulting at McKinsey for 4 years, built and led their healthcare analytics service lines, joined Google, did a lot of product-facing work there, joined Komodo Health at its inception, to build out as head of product and head of data platforms. I've built out what I've described as now being called the healthcare map of the US, as well as a number of our enterprise and software solutions. And excited to chat today about what we've found in terms of COVID and also share with the group the power of real world data.
Wonderful. Well, thank you so much for being here to chat today. So, before we dive into the topic, I was hoping maybe you could tell people a little bit more about what Komodo Health does, just in case they're not familiar.
Sure. Komodo is a healthcare analytics company. We have built the most actionable healthcare map of the US market. And what I mean by that is that we trace the journey of 325 million patients, the providers and institutions where they seek care, the therapies and interventions they use to treat those conditions, and the outcomes that relate to that. And what's really powerful is that we're able to serve life sciences companies, payers, providers, patient advocacy groups in order for them to understand disease burden, in order for them to then map that to standards of care and ideally optimize the patient journey so that every patient is getting the right therapy at the right time, in the right setting of care with the right provider, and getting to the best possible outcome.
Wonderful, wonderful. Thank you for that. All right, so let's jump in discussing deferral of care, right? And this has obviously become just, a major public health concern. COVID started and we all kind of, went into our little holes, and then we had, public health officials telling us to be very careful, not to be around people, right? Not to go in unless something was urgent. So I think it'd be good maybe just to kind of talk about how we got here.
Absolutely. So when COVID first started, essentially the economy shut down. It's now claimed well over 600,000 lives. And looking back, when the care system, it was a shock because we're used to in-person encounters with providers, but we didn't know how COVID would spread. We didn't know how specific populations would be impacted by COVID. And so the default was, in the absence of any knowable truth, just stop everything that is essentially non-urgent care. And what that led to is a phenomenal drop in a lot of the routine care that patients seek out of the healthcare system. So, for example, diabetics, you need to have your hemoglobin A1C level drawn. You need to have, if you have high cholesterol, you need to have your lipid test done. Those dropped by nearly over 60%. And so it's not that, and the consequence of that is that if you don't have your diabetes or your cholesterol under control, it causes a lot of microvascular damage. And that's the type of damage that leads to strokes or to heart attacks. And so it's oftentimes very concerning when there's a jolt to the system. And now you have folks that have comorbidities, but maybe essentially flying blind on the treatment of or the care of their health. And so that was immediately concerning to us. It was concerning to the providers themselves. And to look at higher mortality or morbidity conditions, we had the same impact in terms of cancer. And I can share a little bit more about that shortly.
Yeah, absolutely. Well, I know speaking for myself, it's just incredibly true because I put off all of those routine visits, right? Didn't have my teeth cleaned, wasn't getting checkups. And everyone around me wasn't either, right? Unless it was acute. People that had acute conditions were still going in, but unless it was acute, it was just kind of like, we'll worry about that later, right? Which obviously isn't a good strategy at all. And I've heard people say, Oswin, that, COVID is going to be with us for years, even after it's over, especially the mental health aspects. I've heard from a lot of people that apparently that isn't even going to start showing itself for probably another year or two, because a lot of people are still kind of just in it right now. Like we're still dealing with it, but that stuff in a year or two is really going to, show itself and the stats are going to go up there.
Yeah, I mean, COVID is going to become endemic to the population in the same way that flu is. And so I think that's largely unsurprising. And, we're going to see a kind of ebb and flow of different mutation types. We're going to be getting our annual vaccination. So, I mean, for example, this past spring was devastating to India and a number of other sort of high density countries. There's also there's over 100 countries that have not gotten a single COVID vaccine yet, and that's extremely troubling in terms of both, not just in terms of US disparities, but also in terms of global disparities. And I think that the challenge is going to be, how do we as an industry and as a population, what do we need to demand as changes from the system? What have we learned from COVID? And how are we going to minimize the ill effects and the morbidity and mortality associated with COVID and kind of try to find the silver lining within COVID? Because it has created some changes in the healthcare system that are positive, but we need to be able to sustain those changes, especially in the context of disadvantaged populations.
Yeah, absolutely. No, I couldn't agree more. I mean, you look at things like telehealth, for example, right? And just how quickly, that has increased. And, we're creatures of habit now. So, now that we're using telehealth and these other sorts of services, we're not going to want to go back. We know how easy it is just to now talk to your doctor, over the phone or over some sort of, technology. So why would you now want to have to drive to the doctor's office? So for me, things like that I see as the positive change, where I think that it would have probably taken a really long time. I think that a lot of people were fighting the adoption of some of these technologies. And I feel like that for me has been a huge positive.
Based on our data on that particular topic alone of telehealth, we essentially saw in some care systems 6x the number of providers that started providing telehealth services versus the pre-COVID norm. And I think that's awesome, especially when you're seeing a lot of all the different specialties signing up for it, and it becomes a institutional priority. And the second piece is we saw 10x the number of patients that not only had access, but chose to capitalize on that access to telehealth. And, I think it's interesting, right? Like you have like Uber that brings you meals and brings you groceries. And now you have telehealth capabilities that can bring pipe care directly into your home when you need it, somewhat on demand, and it's high quality. And I think that actually provides a lot of opportunities and scaffolding to get care to the populations that need them most. Oftentimes the disadvantaged populations, they may not have a car, but they have a cell phone connection, and being able to get on time, high quality care without any sort of like, events or challenges in that frictionless process towards that care. I hope those changes are here to stay.
I really hope so as well. I mean, I'm sure we'll probably see it drop off some is my gut, but I feel like you said, it's institutional now. Like we're so used to it now and we've seen how well it can work. Obviously, certain conditions you're going to have to go in. But for me and working full time, I absolutely love it when I can quickly call my doctor and do this telehealth visit. And having a young son, I mean, there's all sorts of things. I'm like, I have no idea what this is. Almost every time they're like, oh, don't worry about it. I'm like, oh, but it only took, 20 minutes versus before where I'd have to like get in the car and drive somewhere. But I would love to hear more about the research that you did specifically on breast cancer and also, what some of the findings there were, Oswin, and then if we could maybe too, what potential, silver linings or what it brings to light from there.
Yeah, so there are things that telehealth can do, and we've been talking about those a little bit. But there are things that they can't do, which is it's not going to, you're not going to have cancer screenings that are done, and maybe we'll get to that world in the future, especially with a lot of the sort of blood-focused tests, but we're not there yet. We saw immediately in the spring of 2020, we saw a 90% decrease in the number of colonoscopies, and about 70 to 80% decrease in pap tests and mammograms and biomarker testings for disease like multiple myeloma. And I would caution folks, and the reason I draw caution here is it's not that folks are not getting cancer, they're just not getting screened for it. And that's extremely troubling for us as an industry where you get, patients and you have these guidelines and you want them to adhere to the standards of care. And so the recognition that, hey, there are some things that can be done remotely, but there is still absolutely the place for in-person testing, diagnosis, the conversations and that personal interaction with your provider, and all the other elements of the, sort of the healthcare journey that drive better outcomes and cannot be displaced by just pure technologies alone. And so the reason I offer this is we need to know when to use technology. We also need to recognize that technology is not a proxy for everything. And it was extremely concerning to see these screenings of the very high mortality cancers drop basically off a cliff. It did recover in the latter half of 2020 and into 2021, but it has not yet regained kind of the steady state that we had going into COVID. And, I think that's where it's important, where providers need to constantly engage their patients and their in their practice to make sure patients are adherent to the standards of care. The standards of care are there for a reason. And, it's important that we have the right conversations at the right time with our patients and get them into the office and into testing when needed.
Yeah. And also with surgeries were delayed as well, right?
Absolutely. And so we saw a massive drop in, elective surgeries, and that is totally understandable. But what we're also finding is a troubling, almost like, for example, in things like colorectal cancer, you would expect to see resections of the bowel that has tumor burden. And we also saw that drop off. So what it means is folks are not getting screened for the cancer, they're not getting diagnosed, and therefore they're not getting the condition, and they're not getting the treatment that they need. Yeah. And so in conditions like, for example, colorectal cancer, the 5-year survival rate when you catch the cancer very early is 90%, which is phenomenal. But when now what we're seeing is that there's actually a new like in terms of the diagnosis of colorectal cancer in a rolling 12-month period, we're down by 30%. So that doesn't mean the colorectal cancer went down. It simply means that we have failed to identify early stage cancers with colorectal cancer patients. And those patients are going to come in with increased tumor burden, later stage, dropping survival rates, and also dropping the number of therapeutic choices available to colorectal cancer patients.
Mm-hmm. Yeah, I mean, it has implications across the healthcare system, right? Because, I've heard with surgeries being reduced, that affects the hospitals quite a bit because they make a lot more money on surgeries versus some other procedures. And so it's like, well, then the hospitals are struggling, right? So there's all sorts of just these ripple effects. I love that you guys call it that because it's true. It's like all of it is connected.
And I think what's oftentimes most troubling is, a lot of these like hospitals operate at very, very narrow margins. And the margins are even narrower, especially when you go into underserved areas and in rural populations. And so they're running on the razor's edge there. And so when preventative care is not happening, when elective care is not happening, when necessary care is not happening, that essentially not just endangers the patients whose care and diagnosis has been delayed, but also endangers the lifeline to that entire population in terms of access to care. And I think that's the more important conversation around, like, how do we prop the system up and make sure that we're not, New York City, Manhattan has one set of disparities, but making sure that you're not taking away the only hospital within, a 300-mile radius. That has been relatively understudied, but equally important.
I could not agree more because, these numbers around the amount of rural hospitals that have closed are staggering, And I've had this conversation with a few people. Well, then they're like, oh, but thank God we've got all the telehealth services and all that. True. But like, you and I were talking about earlier, it's like, yeah, but still there's certain things they need a hospital for, right? And if that hospital's now even farther away, do you think they're going to go? It just, it's like, we're not making it easy. So maybe this is a good time for us maybe to talk about some of the solutions, right? What can be done, because, this has brought to light, a lot of the opportunities in our healthcare systems and honestly weaknesses.
Yeah, so to talk a little bit around, start a little bit on what has COVID taught us. First of all, it's accelerated the adoption and access to telehealth, which I think is net positive, but we still have more work to do. Digital side has been really interesting because, it's not like, new medicines, new treatment modalities, changes in standards of care. In fact, I would argue that COVID was the fastest instrumentation around establishing a standard of care. Like, we went from really high mortality rates to, we're just going to invert the patient bed. We're going to make sure that the fluid is draining by the force of gravity and like reducing mortality rates in ICUs by 50%. Like, that was a conversation that was instrumented purely by digital through providers and institutions. And that's phenomenal. Right? Like, that actually shows you the power of not just data, but it shows you the power of digital in terms of helping to collect, curate, and then disseminate standards of care. And so in conversations that I've had with life sciences companies, they're actually seeing like, oh, wow, our providers really like consuming micro content that's relevant to their care system, understanding the comorbidity of COVID and how it disproportionately affects another, specific population. How does COVID interplay with, hematological malignancies? How does it interplay with specific, diabetes or chronic care conditions? And digital has actually enabled all of that. And so I think that it's extremely powerful as a tool and resonant of kind of the broader themes that we're seeing at this conference this week. To talk a little bit around some of the downsides or the spotlight, it really highlighted disparities, right? So disadvantaged populations. What does care look like on the other side of the train tracks, right? So we have half the population that's gotten, more than 50% vaccinated, at least one dose. And so, which populations are underserved by this? We all think about, oh, well, we just go to the CVS and Walgreens around the corner, and of course they're going to have a vaccine, but that actually isn't the case for a quarter of the entire country. And, so there's a conversation to be had like, oh yeah, well, there's a Walgreens, within 5 miles, but like if you're a low income resident, like 5 miles could be 500 miles, it's all the same. And so I think that it's really shone a spotlight on what are the disparities in care, what are the underserved populations, and what are the new vectors that we need in order to drive education and adoption of the standards of care for those patients.
Yes.
The last piece that I would also highlight is that it massively disrupted the clinical trial system, and which obviously has new treatment modalities coming out all the time. And the downside is that it slowed down trials considerably, sometimes shuttered them. The upside is that the industry realized, well, can we decentralize the trial? So to use less technical language, can I have patients flying in or doing televisits rather than flying in for all this work that's routinely done in the context of a clinical trial? The second piece that it also highlighted is, well, do we actually need to collect as much data as we actually do as an industry versus, hey, we already have a ton of data around the encounters and the journey of hundreds of millions of patients before them. Do we actually need 500 patients for this trial, or do we just need 300? And having that statistical powering, I think, is super important because it drives efficiencies into the system. In the context of synthetic control arms, you basically could argue that you do not have you don't even need to have a control arm that's good for patients because they don't really like to be, focused or get a placebo pill when they have cancer. And so it's taught the industry in a number of really deep ways how to engage patients, how to treat patients, and how to maintain or strive to better outcomes and a better patient journey experience.
Yeah, I couldn't agree more. I mean, the acceleration of real world data and evidence has been incredibly exciting. And that's another thing too, where it's kind of like, I'm curious where the regulatory agencies end up on some of these things, right? Like how much of it now can be accelerated even more and stays with us. The other thing I wanted to ask you about is, the collaboration across healthcare. I think one of the issues we've had with our healthcare system in the US is the siloed approach, right? But I do think in some ways COVID helped with that collaboration. And I did see a lot of it in some really interesting ways, with government and industry. And, but I also think too, it's like there was a moment when I felt like the collaboration was happening more in healthcare. And now I'm feeling it go back to everybody's in their own corners again. And I'm curious what your thoughts on that are.
So I'll give you a very short answer on this, which is for very long as an industry in healthcare, what does value mean to all the stakeholders in healthcare has always meant very different things. So in the context of payers, it's meant medical loss ratios. In terms of, life sciences companies, it's like, okay, are they using, my particular therapy versus not? On the provider side, it's oftentimes like, okay, well, like, are we able to maintain the margins we need to run the business? But if you realize that I didn't use the word patient anywhere in that, right? And so the very, very I would say skeptical view of the care system is like, well, how do we actually make the system more patient-centric? And what I really like is that through the use of data, by understanding the disease burden of populations, you can then talk about the contribution and the attribution of patients getting their optimal care and optimal outcomes. And you can map that back to care teams, to payers, to plans, to a particular therapy or a particular pill. And we have all the data we need in order to do that. And so I feel like there's a lot of players in the industry that do not get the credit that they deserve for driving a better outcome. And there's other ones in which we will study it and we'll say, hey, like, you know what? You shouldn't naturally own the risk on this population because you're not able to get them the care that they need and the outcomes that they need at a suitable price. So you should fundamentally like let another payer, provide the care that's needed and drive efficiency into the system. And so I think we're going to see a lot of that actualization instrumented through data. And I think COVID has kind of driven the tailwinds of using data for those types of purposes.
Mm-hmm. Yeah. I think you're right. And I think too, a lot of different stakeholders found each other during COVID, right? Because they had to, it's like they were forced probably into conversations that they might not have had otherwise. And I'm hoping some of those collaborations really, yield results for years to come, because there is something really interesting, that we're all in this together. We're all moving in the same direction. So I'm hopeful. And to your point, data. I mean, when you have data that underpins it and you can see where improvements are needed, very clearly, like the work that you guys are doing, the study that just came out, on colorectal cancer. I was just reading that one this morning, the research that you did with Fight CRC and the younger colorectal patients first presenting in the ER. That's huge. It's such an important data point, because then the ER doctors need to know that, and have the right conversations at the right time with these patients. So, I mean, the work that you guys are doing, I think, has ripple effects in and of itself. So I honestly, I don't have any other questions for you, Oswin. Is there anything else that you want to add or shine some light on?
Absolutely. Thank you for having me in today's session. I would just, for the audience, I would love to share that technology is an enabler. It does not solve all care challenges, but through data, we can understand where we need to go as an industry, and we can understand the populations that are left behind. We can understand the populations that are underserved. We can understand where we need to direct resources, especially in the context of COVID. And we need to also understand places where we typically overinvest. And so I feel like a lot of the traditional biases in the system are almost getting spotlighted now. And hopefully, coming out of COVID, we have a digitally enabled, data-driven view of driving education and adoption of the best possible care standards for patients. And so I'm excited that I was able to share this conversation with you today. COVID has, there is a small silver lining coming out of it, not in any way to overlook or overshadow the catastrophic loss of life as well as livelihoods.
Yeah. All right. Thank you so much, Oswin.
Thank you.
good afternoon, everyone. My name is Sergey, and I'm a CEO and co-founder of OneGenesis. And today I will be sharing our experience in building the ecosystem to accelerate collaborative research. Now, OneGenesis so far has been active in 3 major regions: Asia, Middle East, and EU. We have been founded 2 years ago in 2018, and we currently provide access to more than 1 million disease-specific patients and data points worldwide. We have been partnering with patient organizations, research institutions, hospitals, and biopharma, as well as have done quite substantial work with COVID data related applications, where we are doing COVID data curation for multiple governments and clinical trials as we speak. Now, our vision is very simple. We want to equip research institutions with means for compliant data showcasing, consent-equipped data showcasing, study sponsor attraction, and facilitation of collaborative research. Now, why are we talking about this in the very first place? Now, OneGenesis has defined 4 major issues or challenges that prevent study sponsors and research institutions to directly exchange the information about the clinical data assets and patient reach available with the hospitals or other clinical organizations, such as, for example, patient organizations. Fragmentation and traceability of data is the first one. Data is always very siloed with the institutions, and they do not have the capacity or the technological tools to showcase it or to even normalize the data sometimes. The regulations are conflicting jurisdiction to jurisdiction. Consent is very old school, it's not digitalized, so it's not transferable. And ultimately we need an end-to-end digitalized consent management process to make any sort of data sharing or dynamic patient onboarding into trials become a reality. And then the cadence of the collaboration cycles between the institutions has been inherently very slow. Now with COVID, all these issues have amplified 10 times because the limited and siloed data sets basically became the major issue of why, or the major reason of why the time to discover treatment was so slow. They limited cross-institutional collaboration. The data was scarce and still is scarce. It is very often unique and localized to very specific geographies or institutions, always changing. And information is moving at a weekly pace because we're in the pandemic and things rapidly change. Now, essentially, the problem of being able to understand which data assets and which patients are in which institution and being able to onboard them dynamically into a clinical trial has become very, very, very acute, even more acute than in the normal environment. So at OneGenesis, we differentiate between 2 approaches of how to identify onboard and onboard patients into studies. One is institution-specific, and the other one is the population engagement approach. I'll start with the institution-specific one. Now for this, OneGenesis has built its own end-to-end ecosystem of enabling study sponsors to identify target cohorts of their interest and dynamically onboard them directly at the hospital level in any sort of study that they wish. Now, for this, we have built 2 key products. We have built OneGenesis Curator, which we call the handshake space, which initializes the collaborative research between 2 key stakeholders, data publishers and data acquirers. Now, through Curator, data publishers are able to safely expose or safely publish the anonymized meta information about the patient groups and the data sets that are available with them. Now, this information is queryable by the potential sponsors that can shortlist the cohorts of their interest and request them directly from the data custodians, the data publishers. So there is no middleman, and OneGenesis is simply a technological enabler of this process. Now, once the requests have been processed, the data publishers can dynamically engage and onboard the patients into a study using our second key product, OneGenesis Themis, which is our own consent management API, which has digitalized consent management process end-to-end. It can be adjusted to specific regulation, and it can be compliant to specific regulations. And this is where basically dynamic onboarding of patient happens. If the engagement is needed, OneGenesis has developed a range of tools like surveys or side effect monitoring, which enable additional patient engagement on the institutional level and custom cohort creation as well. So at the end of the day, and in terms of pandemic data curation as well that we're doing now, hospitals, biobanks, pharma, and academic institutions are basically using the Curator to initialize collaborative research. Now, Curator has 2 parts to it. One is the investigator-centric part, where we basically focus on real-time cohort identification, so the query tool, which you see on the left. and the patient recruitment module, which is the consent management module, where the clinical investigator or the representative, the sponsor representative, can offer their own consent management template, and the clinical investigator on the hospital level can actually oversee the consent agreements that have been sent out, have been signed, revoked, or modified in any other way. Now, on the patient side, we have a patient-centric interface, which also handles consent management, where patient can actually access all the consent requests coming to him or her, revoke them, modify them, accept them, and basically perform every other action that is required by the legislation in a specific geography. Now, on the population engagement front, we adopt a different approach. We have designed a multi-funnel filtering mechanism where we basically create custom cohorts around certain disease risk or around certain disease by deploying our population-based study tools. And this is where we adopt a multi-funnel approach, where we create, for example, we create a web-based service or a web-based self-awareness service around a certain disease, which engages people of a certain, for a certain risk group, creates the first funnel of potential study candidates based on very basic inclusion-exclusion criteria, and then narrows down the funnel by introducing additional, for example, biomarker exclusion or inclusion criteria, and essentially more sophisticated ways of how to narrow down the cohort of your interest. So at the end of the day, you basically arrive at the cohort from the population engagement methodology, which can be redirected to the study site and basically confirmed as a potential cohort for a clinical trial. A good example for this is Screening Solvay, which we have piloted, which stands for screening.lv in English, which we have piloted in Latvia. It is a breast cancer self-awareness tool, which is used by women in Latvia, women with different risks of getting breast cancer. And this is the approach which we have piloted with more than 5,000 women already, which can be helpful in essentially educating women about certain risks that they have with this specific disease and engage them in prospective studies based on this knowledge they have acquired. Now, our call to action at Longenesis is very simple because our time at this session is limited. Since we normally speed up clinical trial pace, we empower patients to be seen and recruited, we help patient organizations to advocate for patients, and we help to boost collaborative biomedical research. We are looking for new partnerships with biopharma, with research units, to conduct studies, design studies and make studies possible worldwide with custom patient cohorts, as well as we are always willing to partner with patient organizations and help them to promote patient rights and enable their patients to be seen by recruiters worldwide. We have been featured in a variety of biopharma-related press, such as Nature Medicine, Cell Press, for example. We have been through a number of competitions, such as EAT Health, which we have won this year, or a MedTech Innovator, Asia Pacific, and we'll be delighted to answer your questions after this session. Please use my email or any other contact that is provided by the conference organizers. Thank you very much, and I will be glad to follow up on this talk afterwards. Thank you.
Good morning, everyone, and thank you for joining me in this conference room today. I am Sana, the partnership manager at the Digital Pharma Lab. The Digital Pharma Lab is the first independent European accelerator of pharmatech startup. And actually, startups are emerging to provide all types of solutions across the healthcare industry, from providing patient care to designing new therapeutics. This is what we call the pharmatech market. And the development of this solution relies on the capacity to create innovative and fast growing strategy like the unicorn business model. So that's why we will see today what can we learn from pharmatech unicorns. The conference will be in 3 parts. before digging deeper into the subject, here are some key numbers that show how incredible the potential that has pharmatech unicorns to revolutionize the pharma industry. So as of today, there are 31 unicorns in pharmatech, representing more than around 15 billion of investments made by the major venture capital, and with a total valuation of $113 billion. So this represents, in the world of the unicorns market, 8%, which is the part that is representing pharmatech unicorn. And if you compare this to the part of pharmaceutical industry in the world's economy, is more impressive, looking that this industry is really new, because the pharmaceutical industry is a more mature market, representing 1.4% in the world's economy, and because it's fiercely competitive. So market studies show that pharmatech unicorns will multiply by 6 the value of traditional pharma industry, making them more competitive and adding some value. So that's why also study shows that the number of pharmatech unicorns will grow will multiply by 5, reaching 2025. So you heard and you've seen a lot of the word unicorn, but first of all, let's see what is actually a unicorn. So a unicorn is a privately held startup company valued at over $1 billion. The term was coined in 2013 by a venture capitalist based in New York, Aileen Lee, choosing the mythical animal to represent the statistical rarity of such a successful venture. And to give you some example of unicorn, BlaBlaCar and SurveyMonkey are unicorns, and you also have what we call decacorn, such as Airbnb and Uber, which are startup companies valued at over $10 billion. So looking in the unicorn market, we can say that it's a fast growing market actually, because in 2015 there were 82 unicorn, and now as of today in 2020 there are around 400 unicorns. So it's really impressive as they grow, and all the markets are impacted by this race, like e-commerce, real estate, tourism, transportation, and also the health industry. So there really is a need, looking at its impressive race, there is a need to anticipate the future of unicorns, to use them as growth maker. And looking internationally, the market right now is dominated by the US and China, which is where the investments are made, and also where are the unicorns for the major part. Looking in Europe, the UK is in the top rank with 62 unicorns, and Germany is also a good example with 27 of them. Now, if we are looking more specifically into the pharma world and startup company, this is an ongoing revolution. So that's why we call pharmatech. And pharmaceutical companies are actually already investing in areas such as big data, machine learning, AI, technology, data analytics, also combined with digital technologies such as wearable device, like, let's say, a watch, a scale, just to see how people are more accepting using this new tool in their daily life. And that's why HealhTech offers as well opportunities to revolutionize the industry and also enhance the daily life of patients and healthcare professionals. And money invested in digital in the future could be as important as in drug development today. So the door is left open to collaborate with other segments of the health market. The estimation of the global digital health market reaching 2025 is of $500 billion. So this is quite impressive. At last but not the least, let's see what can we learn from the unicorns in the pharmatech market. As of today, there are 150 promising startups in digital health, representing over $15 billion of investment. The major part is located in the US. And most of pharmatech unicorns are really changing the core business of the pharmaceutical industry. So that's why we called earlier an ongoing revolution. And from this revolution, many opportunities can be identified, like innovative solutions along the whole value of chain, promising startups to invest in, and also strong partnership between pharmatech and other digital health market segments. So, in these 150 digital startups, they all are building new model of primary care to emerging tech solutions for providers, patients, and also healthcare professionals. And 22% of these 150 promising startups are unicorns. And if you remember what we said before, it's companies with $1 billion valuation. So if we look at the gap analysis of these unicorns in pharmatech, there are 31 unicorns in pharmatech. This is the fact we told earlier, with 18 unicorns in the US, 6 in Europe, 6 in China. And the majority of unicorns are positioned on the high end of the value chain, with about 40% of them are relevant to research and development. And these unicorns propose to shorten expensive development times, also create added value and optimize costs of new treatments. So this is why looking deeper in these unicorns in the health industry, you can see how the benefits can be maximized. So this is interesting to look at why partnering with a pharmatech unicorn is really interesting and adding value for a mature market, and this partnership could really make pharmaceuticals grow in a way that classically doesn't have the way of doing it. So looking at why partnering with pharmatech startup is interesting, because looking at the view from pharmaceutical, they encounter many challenges such as economics, regulatory constraints, the lack of new molecule, unmet medical need, and also slowed market growth. So innovation is key to address these challenges. So that's why collaboration with unicorns supports the development of big pharma innovation ecosystem. So if we look at the research and development example, it takes 10 to 15 years and $500 million for a new molecule to go to the market. So pharmatech specialize in research and development using machine learning and AI technology can really create additional value for big pharma with innovation issues or a portfolio growing old. And different innovation models depend on the common goal between pharmaceuticals and pharmatech. So alignment on the objectives appear as the main barrier because various collaboration are possible. So getting the right one and getting agreed to what is the vision between the two of them is the main issues. But laboratory and incubators, dedicated entities or affiliates has different way to work. So that's why contact points who understands startups are valuable for pharma companies to build collaborative partnership because it will be considered as the new normal in the future. And according to Pascal Bekash and Didier Tranchet, the Digital Pharma Lab co-founders, the most important to innovate and support the growth of pharma company isn't to work with unicorns, but to de-risk the market using them. So thank you for your attention and feel free to ask me questions after the conference, or you could reach out to me and I will be glad to answer your question or give you more information. Thank you. Bye-bye.
Hello everyone, thank you for joining my presentation. My name is Falko Schmidt. I'm a researcher at the University of Gothenburg, and I'm also the founder of Lucero Bio, a startup that we have created from our research. Today, I talk about fully automated optofluidic manipulation of single cells. I will talk about the current limitations in research and technology, how to solve it, and how this advances the global healthcare industry towards personalized medicine. Individuals are affected very differently by diseases such as COVID-19. We're all very familiar with the disease now and know that people react very differently to it, from showing no symptoms at all to very severe problems in breathing. This is of course not only true for diseases, but also for the treatments that we take for them. A common issue is that most clinical trials are performed on male patients only, neglecting a whole gender and possible side effects. How we react to diseases or medication depends strongly on our underlying genetic variations, commonly referred to as our health condition. So we need to have a closer look and understand these variations on a cell level. The healthcare industry, such as big pharma companies, commonly study the effects of new drugs on whole cell cultures, such as shown on the left. Although they can appear homogeneous, single cells can show unique features such as those seen in the green expression of a protein on the right. Aging is the #1 risk factor for diseases such as cancer, cardiovascular diseases, Alzheimer, and many more. Therefore, it is crucial to understand aging on a single cell level. In order to simplify the complexity of the human being, model organisms, such as yeast cells, are commonly used. We're all familiar with them as we use them for baking bread or brewing beer. Although they are just a single-cell organism, they can provide crucial insight into how aging affects, for instance, the transcription of DNA to the next generation. We work in a collaboration with researchers like Dr. Nick Valkenhusen at Chalmers University of Technology, who perform such replicative aging studies. What they do is looking at multiple generations of yeast cells after dividing and see if and how DNA transcription errors are passed on to the next generation and follow them for many generations after. Some errors get corrected, some are equally copied or get worse. Try to photocopy a photocopy and see how well it looks after a couple of rounds, and you will understand how this effect is causing aging of a whole organism. But there are problems with the current research methods, as they are very labor-intensive. Yeast cells are dividing once every 90 seconds. In order to get enough data and statistics on your experiments, generations have to be closely followed over 90 and more hours. In order to keep track and make room for new generations, all the cells need to be moved and isolated from the rest. Current methods still widely employ microneedles for that, which are very small syringes, despite being highly inaccurate and having a huge potential of damaging cells due to their mechanical nature. In order to solve these problems, we combine 3 state-of-the-art technologies, which are optical tweezers, microfluidic chips, and AI software, as shown in a mock-up of our solution on the left. In combination with commercially available inverted microscopes, as found commonly in laboratory settings, we are able to optically trap and manipulate single cells non-invasively without harming them, as we do not physically touch them or alter them in any way. We provide a microfluidic environment which ensures vital cell conditions for long-term studies, and machine learning algorithms that provide the automatic tracking of different cell types, and much, much more. I will explain those in more detail in a second. The big advantages of this system is the huge amount of time savings through automation of the whole experimental protocol, thus requiring no supervision at all. It is as simple as pressing start and coming back when the experiments are done, such that no expert knowledge on the device and its underlying physical principles are required. And the AI enables us to improve data quality and expands research opportunities beyond current experimental limitations, and therefore costs only a fraction of what current experiments do. Let us start with the first core technology, optical manipulation. Optical tweezers, as shown in the bottom, allow tiny organisms such as colloids, so-called spherical particles, or cells, to be handled with beams of light. Arthur Ashkin just recently won the Nobel Prize in Physics in 2018 for his invention of the optical tweezers back in the 1970s. The principle of optical manipulation works as follows. In a beam of light, as seen on the top, colloids are pushed along the direction of the beam due to the radiation pressure. As the intensity of the beam is highest in its center, colloids are attracted to it by gradient forces, as seen in the middle. Because cells would be just pushed further and further, although centered in the middle, we can't have long-term statistics on them. Now, in order to capture a cell at a specific location, one can place a lens inside that focuses the laser beam to a spot. In a microscope, that is typically an objective with a high numerical aperture. Since the gradient forces are strongest at that focus, the colloid cannot escape, not even along the direction of the beam. Researchers have exploited this to study small forces on DNA, visualize the internal dynamics of cells, or use it for trapping and guiding. This enables a complete new way of handling cells without disturbing their cell integrity. Our second core technology consists of microfluidics that allow us to precisely handle the flow of liquids inside micrometer-sized channels. An example of such a microfluidic chip is seen on the left and is basically the equivalent of an electronic chip, where the electronic circuits are replaced by channels of liquids. But why is that so important? Well, in order to study cells over many hours and keep them alive and happy, they require specific environmental conditions such as correct pH values, nutrient concentrations, and others. In microfluidics, one has dynamic control over the speed and concentration of such fluids. The reason for this are the laminar flows as seen in the simulation of a 4-inlet channel on the right. Fluids are flowing into 3 of the inlets except at a third. One can see a nice straight profile vertically down the channel where the liquid almost don't mix at all and only slightly by diffusion. At the microscale, fluids such as water actually behave different to our everyday knowledge. Whereas the 2 arms of rivers joining can produce strong eddies and turbulence, in such a chip they are moving parallel to each other with only lateral diffusion. Therefore, we can produce microfluidic chips, such as seen here, that mimic cell environments that we can precisely control and allow us to grow cells on a 2D layer for better imaging. Here, for instance, yeast cells have been grown inside such a chamber and are only affected through diffusion from the outside channel. The advantage here is that the concentration profile is radially symmetric, and it is an example of the high degree of control one can have over the environment surrounding a liquid. In this way, microfluidic chips find applications for lab-on-chip devices, where whole organs can be mimicked under laboratory conditions. At last, our automation protocols are based on AI algorithms that enable new levels of recognizing colloids and cells in conditions where standard methods fail or are beyond the capabilities of the human eye, which is typically much better at recognizing patterns compared to standard algorithms. In our research group under Giovanni Volpe, Saga Hegadotti has developed a machine learning algorithm called DeepTrack that is based on a neural network that is similarly built as our human brain. A multitude of neural networks, as seen on the left, form complex connections between each other. Trained on stacks of images from simulations and experiments, the network is able to first detect if there are any particles, then classify if there are, here for example, colloids or the hidden bacteria, and then track them over time. As seen on the right, the signal-to-noise ratio is very low, making it very difficult for standard algorithms to perform well. This software package in its base form is already published and open source and can be modified for one's individual purpose. Therefore, the AI allows us to optimize and control the whole environment from the tracking of our cells to the control of the individual components such as the laser. With that in mind, we can integrate all 3 core technologies into one powerful research tool. We start with a culture of cells made of different types of cells that are inseparable using standard methods. We first have to identify them, then perform the trapping and guiding, and at last isolate them for long-term studies or for extraction. For the identification of the red and blue cells, we can use a customized machine learning algorithm trained on a set of images that resemble the required cell type. This can be based on shape, size, the fluorescence of biomarkers, or any combination of those. After the position of the target cells have been identified, the optical tweezers controlled by our AI traps them, detaches them from the culture, and guides them towards our target position without harming it. All of this happens just in a couple of seconds. Once they are brought to the target location, such as a specific growth chamber inside the microfluidic chip, cells are completely isolated from each other. In this way, we avoid cross-contamination and provide a complete sterile environment required for rare cells. In those chambers, as seen here, replicative aging studies could be performed, or cells can be extracted from the chip for further characterization outside our system, such as in PCR machines. These are of course only examples of what could be done, as the applications of these tools are manifold. I'm showing a few examples here, but they are far from exhaustive. Our tools can be used, for example, in forensics, for the extraction of DNA in difficult samples, in immunology for profiling immune cells, for more effective and also personalized immunotherapy and cancer treatment, as well as virology to understand the host-virus interaction on a single cell level and to develop really targeted vaccine. If you have any more questions or like to know more, feel free to contact me here at the conference, LinkedIn, or via email. Thank you for your attention.
Hi everyone, my name is Noya Chen. I'm an early stage researcher for the HealhTech project. So today I want to talk with you about AI and healthcare. So apparently it has become quite a hot topic in the recent years. A lot of funding, people has flown into this area, as well as investment. This has resulted in new technology and its use in healthcare, and also a lot of startups has been investing in the field as well. So there are mainly three technologies behind the use of AI in healthcare: basically image recognition, natural language processing, telemedicine, and telecommunication. So image recognition is about identify patterns in medical images and try to facilitate diagnosis and treatment. Natural language processing helps doctors and nurses to process the patient healthcare records with EHR systems. And also a lot of smart audio interaction systems these days, and chatbots can interact with patients directly and answer their questions about healthcare problems. Telemedicine, telecommunication, and telemonitoring can help patients to communicate with doctors more efficiently, and doctors can monitor patients, particularly patients with chronic disease, from a distance, and therefore enabling faster and more efficient patient adherence. These apps, including Babylon, as we all know, Babylon is collaborating with NHS to provide remote consultation for patients under a pandemic. And it is also a chatbot, so patients can ask questions on the app. Similar functions has been provided by solutions of Alibaba. However, COVID-19 has revealed problems with our healthcare systems. So there is, first of all, lack of effective diagnosis, treatment, and prevention. As we can see, COVID-19 has spread the globe at the speed that only the Spanish flu in the beginning of the 20th century can compare. And also vulnerable groups, particularly elderly people, has suffered tremendous losses and has been hit quite hard. That's because they were not informed sufficiently about the risk of the disease and how to prevent it effectively. And also there is a lack of medical materials and medical resources because in the beginning of the pandemic, a lot of economies don't have enough ventilators for COVID-19 patients. And even now, there is a lack of resources in a lot of developing economies, such as Afghanistan. They were forced to make their own low-cost ventilators, which of course takes some time. And in the process, a lot of patients had, unfortunately, not received sufficient treatment and died. So the consequences of COVID-19, as I mentioned before, is high mortality rates in several developed economies and also in several vulnerable groups. And there is, on a general level, a lack of coordination between different levels of healthcare service providers, and also between different countries because of a lockdown and social distancing and quarantine rules. If you're a resident of another country, and while the pandemic happens, you can't go home apparently, and you're not covered under the social insurance system in the resident country, you won't get sufficient healthcare in time. And this also has caused a lot of immigrants to flee home because of this reason, and and this move of the population has helped the spread of the disease globally. And also there's lack of effective prevention measures in different economies. The Chinese healthcare providers has been using the image recognition software developed by multiple e-healthcare firms, such as E2. So this image recognition software can effectively lower the diagnosis time from 2 to 3 minutes per image to 20 seconds. So such applications were quickly developed. I think the pandemic first started in China in January, and by the end of January or the middle of February, these softwares were developed already and approved by the regulatory authorities to use in hospitals. So because the sooner you diagnose a patient with COVID-19 positive, the sooner you can perform effective treatment measures on the specific patient, and the sooner the patient can be quarantined, and the less of the risk of the patient can infect other people, and particularly healthcare workers. So that's why healthcare service providers have very quickly mastered the new technology, and this technology also has won a lot of applause from them because of its function. So in Europe, as we can see, TU Eindhoven has developed a smart respirator which can automatically adjust infusing of air for patients under anesthesia. So and also algorithms were used by Oxford University to develop vaccination, because the COVID-19 virus has changed very rapidly, and with the DNA variations, it's much more efficient to use algorithms to find out what are the efficient chemical combination for such vaccination to go into trial phase these days already. And regarding other disease prevention, AI and the use of AI has been quite common in chronic disease prevention, such as hearing loss. I know this app called Mimi Hearing Test has been developed by the German startup, and it has collaborated with the German insurance provider Balmer to help its users to test hearing losses on the smartphone, and also to prevent cardiovascular disease and cancer by controlling weight and monitoring patient adherence effectively. And of course, there are challenges for smart health solution implementation because the healthcare system only just started to implement and use such a technology. The biggest challenge identified by several industry leaders and healthcare policymakers has been data interoperability, because hospitals these days are effectively data islands where they cannot talk with each other about combination of healthcare data. So when we talk about big data, it means the millions of data records. If without effectively communication between different hospitals and different levels of healthcare providers, it is difficult to have an algorithm which can effectively prevent diseases or to perform quite well with rapid diagnosis and treatment. And also relationship with digital twin is changing these days as the technology is evolving. We don't know how the future, how in the future people will see the new technology and where they are going to trust their digital twin, or it is merely a digital mirror used by patients. And also, we don't know if people can trust other smart house solutions, because there has been quite a lot of reports regarding big technology companies using Fitbit and other smart house solutions and to profile their users. So that's why privacy and data protection has become so important for smart house solution implementation. And also particularly in the Eurozone, the smoothing of the differences between healthcare systems has been identified as a very important factor for implementation of the smart house solution. As we know, between Northern and Southern European economies, there is a lot of differences in their healthcare systems. I think the insurance system and the insurance coverage is also different between the Netherlands and Italy, for instance. So if you are a citizen of Italy and you happen to live in the Netherlands and you're already covered by Italian social insurance, that is a lot of trouble for you to access your own health care records in Italy from the Netherlands, and also to have a refund for the healthcare services you receive in the Netherlands. And therefore, smoothing these differences is the first step for implementing smart house solutions. And also for building such a system, yearly you would have to have a centralized health data exchange systems. Yet yearly these systems require a bottom to top data updating system and data reporting system. And therefore, it is quite easy to ignore the local community leads. For example, in the COVID-19 pandemic, on a local level, a lot of communities have found out there has been infected cases in their community, but it took a while for the policymakers to realize it is a new type of virus and there is no effective treatment towards it. And therefore, it is necessary to have a balance between local community needs and the centralized healthcare data exchange system. And also the business model and funding model for such solutions needs a bit of experimenting now, because you can't expect patients to pay out of pocket for all the services and solutions. But as we say, because medical science remains an evidence-based profession, it is hard to prove that the telemonitoring methods and AI have been playing an effective role in, for example, lowering healthcare costs on a national level. And therefore, it is hard for policymakers to take these technologies under public medical insurance coverage systems. And often hospitals, they face a large pool of data from different sources. And they don't have the funding, they don't have the expertise to process the data. And for technology companies, it is hard for them to access the data because the data is very expensive these days to get. And therefore, the use of AI and telemonitoring in healthcare has been quite slow. Because medical science is still an evidence-based profession, it will still take a while for us to have a wide use of AI and IoT in healthcare. And therefore, I hope in the next 5 to 10 years, we can say the wide use of AI and telemonitoring methods to help patients and to help healthcare professionals as well. And on a larger scale to reduce healthcare costs for the system. Because with aging, healthcare cost is projected to grow a lot in the next 10 to 20 years. And I sincerely wish the emergence of new technology can help us to control the cost of healthcare. So I hope you learned something from my presentation today. And if you have any further questions, you're welcome to contact me personally on this issue. And thank you so much for listening to me today.
Hello, thank you for joining today. My name is Marta and I'm a UX design consultant specialized in digital health. So part of my job is conducting independent user testing of digital health and well-being applications and publishing guidelines, best practice, and recommendations for health tech entrepreneurs. So today I would like to talk to you about 5 principles for creating health apps people love. So if you are a health tech entrepreneur and you're creating an app for patients or any kind of app that will help people start healthy lifestyle or maybe adopt healthier habits, these 5 principles will help you make sure that the product you're creating is really engaging. People do want to use it and they do want to come back to it again and again. So the 5 principles are transparency, autonomy, relevance, simplicity, and value exchange. So let's talk about the first principle, which is transparency. So this principle is all about creating trust and credibility. So for people to use your product, they have to trust it. And that means basically 2 things. They have to trust that their health information is safe within your product, and they also have to trust that the health recommendations that they receive from the app are credible and trustworthy. So the best way to do it is really just through transparency. So being open within the UI of your app about how you use people data, why are you asking them to enter this data, the intent of the product, and where the health information and recommendations are coming from. So as an example, we have an app called My Possible Self. So this is a mental health application. So they are explaining a little bit about what the cognitive behavioral therapy is. They're not going into huge amount of detail in terms of like clinical background, but that's fine. That would probably be too much. It might be too difficult to understand for people. So they're just really explaining a little bit about the method in a plain, simple, understandable language, which is again just building that credibility so people feel like they can actually trust the recommendations because they're approved, standard, tested methods. We can also see that in the sign up screen, they have 2 links. So the first one says, why do we need this? And the second one says, your rights explained. So both of those places will take people to somewhere where it just explains a bit more about why they're asking for information, how they're going to use it, how people can delete it and revoke their consent. So both of those approaches, they're really just creating this trust and credibility. So people feel safe that when they enter their health information, they know what's happening with it, they know how it's used, and they know that the methods and the recommendations they receive from the app are also credible and based on reliable resources. So the second principle is autonomy. And this principle is all about giving the user a choice and creating a sense of control over their experience and their journey with the product. So autonomy is actually one of the most basic human needs. We need to feel like we're making our own choices. We need to feel in control. And it's also one of the most fundamental principles of usability and UX design in general, not just for health products. But specifically for health products, what that means is that when the apps are providing any kind of recommendations or telling people what to do, telling them what their goal should be or what their target should be, in those cases it's very important that the app has informative and supporting tone, and it's guiding the user and curating relevant resources, but it doesn't feel like it's forcing the user down a path that the app wants for them to take. So the first example that we have here is an app called 30-Day Fitness. So here what they're doing is they allowing the user to choose how much effort they actually want to put into their health improvement journey. So this is very important because there will be people with different levels of motivation. So some people will be quite motivated and quite confident that they can actually start an intense program. But there will also be people that are beginners and are at the beginning of their health improvement journey. And maybe they're not so confident that they can actually stick to their goals. So maybe they just want to start with a chill program and start with maybe 5 minutes a day. So it's very important that the app is giving them this choice so they can choose the program that's best for them. The second example is an app called MyPlate. So this is a food tracking app. And here they are allowing people to choose targets for their nutrients. So they can choose how the percentage of protein, fat, and carbs that they want to intake throughout the day. So this example actually came up in the user testing sessions that I had. And one participant was following a ketogenic diet. So that's a diet that involves having a high fat intake and low carbs intake. So that participant commented that the app that they were using at the time didn't allow them to select their own targets. So they found that very annoying because what was happening is that the app just kept sending her notifications and nagging her that she's having too high fat intake, which was something that she actually wanted. So she found that very annoying and very restrictive that she couldn't make her own selections. So these are two examples of why having a sense of control and having the freedom to make their own choices and decide on their own targets, on their own goals, and on the effort that they want to put into the health improvement journey is very important. So the next principle is relevance. So this principle is all about personalizing the content and making it very relevant for the specific user. So nowadays there is tons of health information online, and that's good on one hand because it's very accessible, so everyone can find answers to their questions. But on the other hand, what's happening is that it's actually quite difficult for people to do their own research and sift through all that information to try to understand what's actually credible, what's actually relevant to their own particular case. So this example we have here. So this is an app called Caria, and this is a menopause tracking app. So in the insights section, I can see that they're giving me suggested tips. But what's interesting is these little labels where it says you logged alcohol or you logged caffeine. So what this app is doing is based on my tracking entries, and they are actually personalizing the tips for me. So if I tracked in my journal that I had some alcohol or I had some caffeine, the app will straight away pull up the relevant content, and straight away I can just learn what is the link between alcohol and menopause, and I don't have to go out of my way to Google and try to do this research on my own. The most relevant content is just presented to the user at the most relevant time. So the next principle is simplicity. And this is all about being very clear on what's like the one thing that your app does for the user and what's the one problem that you really want to solve for the person using this application. So when the user opens the app, they land on the homepage. If they were only going to do one thing, take one action, what is that action that they should take? So in this example, this is an app called My Life. This is meditation and mindfulness application. So as you can see, when I land on the home screen, there's only really one thing that they're asking me to do. So they're asking me to start my check-in flow. So that's my mood tracking, to say how I'm feeling that day. And it's really super clear. There's only just one button saying start. So I immediately see what I'm supposed to be doing in this application. And then once I completed my check-in and indicated how I'm feeling that day, based on that, they will recommend relevant mindfulness and meditation sessions based on how I'm actually feeling that day. So as you can see, this approach is creating very intuitive, very simple experience where, to begin with, they're only asking me to do one thing, just to start my check-in, my daily check-in, and then everything else kind of naturally follows through. So one thing very naturally leads to another. And that's a great approach to create very simple, very intuitive experience. The second example is very similar. It's an application called Flow. So this is a period tracking application. And it's a very similar case here where on the home page, they're really just asking me to do one thing. They're just asking me to track my period and track my symptoms. And then they also have a community section, and they also have this health insight section. So that's the educational content, articles and courses. So again, based on my tracking, they will recommend relevant articles. But every time I open this app and see the homepage, there's only one thing that they're asking me to do, and it's very, very clear what I'm supposed to be doing in this application. So the last principle for today is value exchange. So that means that the app shouldn't ask too much from the user before it provided some value to the user first. And the area where I see a lot of apps getting it wrong is the onboarding flow. So a lot of the time, the onboarding flow focuses on getting what they want from the user. So they want their email address, they want them to opt in to push notifications, they want them to allow location services, and they're just asking, at the point where the user doesn't really know the product yet. They don't trust it, they've not tried it, they've not seen it, so they don't know if this product will actually provide value, and they don't know if they actually want to use it. A very good example is an app called Grow. So these first three screens are part of the onboarding flow, and here we can see that, for example, they're asking me about my focus. So I can see that they're really focused on me. They're trying to understand what my goals are, what I want to achieve. And then when I get into the app, they're giving me one small action to do. So it just says, smile to yourself because you rock. It's a very small action. I can do it immediately. And once I've ticked off that action, they're giving me an achievement, a badge for completing that action. So straight away, within the first maybe 30 seconds of interacting with this app, I understand how this app works. I understand how it can help me. And I'm even already getting some sense of satisfaction because in the first 30 seconds, I've already done something positive for myself and I've already been praised for it. And then as you can see, they asking me to create an account while I'm already within the app. So if I go into my profile, I can see that I've been using this app as a guest, and I can create my account. So, and then I can even see that if I create the account, probably I will be able to see more of the achievements and the badges that I've received. So if they asked me to create an account straight away at the very beginning of the flow, like most apps are doing, that wouldn't be as compelling for me, because I've not tried this app yet. I don't know how it works. I don't know what the benefits of creating the account are for me. So I would be much less compelled. So this is a very good example of how the app can really focus on providing the user the value first, in the first interaction, in the onboarding flow, before they ask something in return. So these are the 5 principles for creating user-friendly apps. Thank you for joining me today. And if you have any questions or would like to chat about any of those topics, obviously I'm more than happy to engage in the provided LinkedIn group. So by all means, please do get in touch. Thank you.